Rock from the Heart's mission is to connect survivors, caregivers, medical professionals, researchers, and others affected by thoracic aortic disease. Rock from the Heart supports families from diagnosis to recovery by connecting them with resources and information that is often hard to find. We strive to organize events that are affordable and accessible to people at all income levels. Thank you to sponsors and supporters of Rock from the Heart to keep this core to our mission. Thank you to all of our speakers who have put such effort into providing their expertise and experiences to forward understanding of aortic disease and its treatment. On each table, you will find an index card along with pens for our Q&A. We have cards again at each table, and you are welcome to write questions you have for the speakers. Please include your email, and we will connect with you with an answer if we cannot cover it at any time today. So it is an absolute honor to be here today, surrounded by some of the brightest minds in medicine, individuals who have dedicated their lives to advancing cardiovascular health and saving lives. My name is Emily Schumacher, and while I stand here today as Miss Minnesota, my true passion lies in the world of medicine, specifically in cardiovascular medicine. My advocacy in heart health began nearly a decade ago when I was 15 years old, and since then, it has shaped every part of my life. I am a certified CPR and AED instructor, and have trained over 4,000 individuals in life-saving techniques. And I work in the emergency room, where I see firsthand the devastating consequences of sudden cardiac arrest when immediate intervention isn't available. That's why I'm committed to changing the system, so that life-saving tools and trainings aren't just available, but expected in every space, just like fire extinguishers. One of my biggest focuses right now is working with Avive Solutions to push for a future where AEDs are as commonplace as fire extinguishers, not just in schools, gyms, or businesses, but in our homes. We lose over 350,000 people every year to sudden cardiac arrest, and 73% of these cases happen at home. Yet most households don't have an AED. We have long accepted that fires are an emergency that require immediate responses. So we put fire extinguishers in homes, businesses, and public buildings. But cardiac arrest is just as time sensitive. Every minute without defibrillation reduces survival chances by 10%. It's time we treat AEDs the same way. To drive this initiative forward, I have taken my advocacy to Capitol Hill, lobbying for policy changes that make AEDs more accessible and affordable. Through partnerships with organizations like Avive, the American Heart Association, and Parent Heart Watch, I've had the opportunity to meet with lawmakers pushing for funding, legislation, and awareness campaigns that emphasize the importance of a widespread AED placement. If we can make AEDs a household standard, just like smoke detectors and fire extinguishers, we can dramatically increase survival rates of sudden cardiac arrest. At the core of everything I do, my mission is simple: to save lives through preventative cardiothoracic care. And I know that mission is shared by so many of you in this room today. Together, through advocacy, innovation, and education, we can create a heart-healthier world. And with that, I would like to introduce our first speaker of the day. Karen Anderson of Aortic Hope. Ace your healthcare journey. Advocate, communicate, and educate for optimal heart health. Inspired by her professional journey with aortic dissection in 2015, Karen Anderson established Aortic Hope in 2016 to provide a supportive community, educational resources, and hope for others during their recovery and management of aortic disease. She is also a certified patient leader, which enhances her ability to provide strong advocacy. When not advocating for aortic patients, Karen enjoys spending time with her husband, Joe, in their Bel Air, Maryland. Thank you, Karen, for your continued support of Rock from the Heart and sharing a positive patient voice with aortic disease. Please welcome Karen.
turn my head a lot. I didn't anticipate that I'm going to have to look at what I actually need to talk about by doing this. So bear with me here, and let me get the glasses because I'm in that age. So before I get started, first I just want to say thank you to Amy and Pete. It's such an honor to be able to be back here again speaking to you. Although my sidekick, Dr. Ben Udelman's not with me, and I know he's much more entertaining than I am, it's always a joy to get a chance to see familiar faces and then meet new community members and other individuals that are here for the partnership. So, as it was mentioned, I am a survivor of a type A aortic dissection, and I also recently became a certified patient leader. And I'm one of the founders and the president of Aortic Hope. Aortic Hope is a globally recognized organization that is patient-led, so we provide a variety of services such as support group meetings, even to individuals in Canada, as well as Spanish support group meetings. We have a lot of live interviews and interactive events that take place on our YouTube channel. We also offer a community. So beyond just the educational events, we have things like Qigong. We offer mindfulness. We offer the aortic artist who's here with us today. We also offer an aortic kitchen. So it gives patients an opportunity to kind of just exist and live their best life with other patients that have a similar condition. So one of the things that I was asked to do was to talk about okay, you guys can still hear me. I was asked to speak at a presentation in Scotland in the fall. And this was through Think Aorta, the Think Aorta campaign, which is in 15 different countries. It's a very pre-active campaign. And I was supposed to speak with Dr. Ben Udelman from Maimonides Hospital in Brooklyn, New York. We were supposed to talk about the patient-physician relationship. Okay, he's not my physician. He's never going to be my physician because there's a lot that gets uncovered in surgery, and I don't want him to see me like that, so he's not going to be my physician. We became more colleagues, and he's our clinical consultant, but oh my gosh, I was racking my brain. How do I talk about our relationship other than how it's become professional? And one night when I was in the TikTok abyss, it dawned on me. And so I'm really excited to share this with you because I think a lot of you will feel similarly to what I feel like. All right, green means advance. Okay, this is Ben's slide, so I'm going to be Ben, not as charismatic. But the history of the patient-physician relationship according to Dr. Udelman. Basically, the doctor tells you what's wrong, and the doctor tells you what to do. You go do it. You're going to get better. And if you don't, you go back and you repeat starting at number 1. That's kind of how the physicians look at things. Most, not all, but most physicians look at things. Now, one of the things that they're starting to realize is there is a change and shift in attitude from the physicians because the patients are now starting to get a lot more involved in their shared decision-making, these buzzwords that you may be hearing in the community. So here's a story from Dr. Weibel. It was a Friday night, and the patient called in for an antidepressant. The physician picked up the phone and said, "Hello, how are you? How can I help you?" And the patient answers and says, "Is this the doctor? It's almost midnight, and you answered the phone, and, well, things are kind of tough right now. I was just calling so that you could prescribe me some of my antidepressant medications." So the patient and the physician talk about their challenges. And "Christy, I'm happy to see you Saturday morning in the office," the physician says. And Christy responds with, "I just can't believe that you answered the phone. I'm so excited. I actually don't even feel depressed anymore." And what they realized is physicians making themselves emotionally available and accessible is healing. So maybe the physician was part of the healing process. Maybe they're part of the medication in and of themselves. So recently, well, not recently, but it's actually recently some of the results have been published, but starting back in 2019, Maimonides Hospital started this research study about the prevalence of PTSD in people with aortic disease. And so I'm going to do my very best. He told me what these all meant. I wrote down the notes. I'm going to do my best to explain this. I have the general sense of this. But basically, and this was presented at a symposium in 2022, what you're seeing here is if the background of the US shows that there's a prevalence of 5 to 10% with PTSD, People who have had cardiac surgery present between 5 and 20% with PTSD. Cancer diagnosis, people can present with PTSD upwards of 20%. So this give you a little idea of how the AD patients fit in. Type A, by answering these questions, and this was out of, I think, 440 people who answered. Type A showed 45% of them had signs of PTSD. Type B, and if you all understand, type A would be your ascending dissections, your type B would be your descending. We're at 16%. People who have had any kind of surgical repair were at 23%. Those that were sitting in the watch and wait for surgery were down to 12%. And people who just know that they have a family history were still showing signs of PTSD, and they're at 10%. Okay, so this is showing the qualitative analysis of basically your quality of life. And what this shows here is based upon the responses to some of the questions, about 6% of people that have aortic disease felt that they started feeling a sense of limited sexual activity and intimacy with their partner. You have all the way upwards of 77% of people felt that they had a perceived impairment in their quality of life. Now you have to understand that about 56% of these people that were polled, they already had some type of known psychiatric complaint. Okay, this is the same, but he circled the 56, so we're going to move past that, and we're going to move past the 6. Okay, this stressed me out, but he explained it to me, and I took notes, so here we go. All right, basically what this is showing, if you take a look in the top upper left, these are people who had elective aneurysm repair, and over time, you're seeing a decrease in people with self-perceived PTSD or health-related trauma and some mental health issues. And if you look down on the lower left, you'll see the type A dissection repairs. They dropped even more. But what you're going to see here in the middle is people with type B. And I found this very fascinating. So the individuals that have a type B repair, who are typically medically managed, are showing an increase over time in stress and PTSD-related symptoms. And the takeaway really is, let me pull this back, the takeaway really is that this is really no small diagnosis. This is no small matter. And they think that the reason why the stress is going up for individuals who are just sitting there with a type B, knowing that they have dissected, but they're just being managed with medication, is that there's a lot of knowledge that's out there. And maybe this knowledge is we're just going to have to keep waiting and keep having you have scans. And over time, the stress and the anxiety builds up. And so that's the trends that they're seeing. Okay. All right, now this is my part that I know very well. Okay, let's talk about the relationship of patient and physician. Because when I had to come up with this initiative, I really had to take a look at my own personal journey with physicians, because I am a patient. I might be a patient leader, and I talk to everybody in the community, but I'm a patient. So what kind of patient am I? What kind of relationship have I had? And I believe, and after talking with many, that it's a lot longer than the 5 or 6 he had. Physicians, we go and we tell the physicians how we're feeling, and they tell us what's wrong, right? They tell us what to do. We do what we're told. We keep our thoughts and feelings private, so we're not going to tell them that we read something else on Google, or that we're even feeling ill from a medication, or we're feeling scared or full of anxiety. We don't ask questions. We just zip it, and we hope we're going to get better. And then when we don't feel well, we stay quiet. We call the physician only at the last minute because we don't want to annoy the gatekeeper who answers the phone, because they're really special and important to us. And then when all things go awry, we go back to number 1. So it's a much more extensive process, and that's because we have a lot of emotions that happen really, really fast in this process of not feeling well. According to the Journal of American Medical Association, it's actually been noted that between 61.4% and 81.1% of patients actually withhold medically necessary and relevant information from their physicians. And the primary reason for withholding this information is because we're scared we're going to be judged. I mean, can you imagine calling your doctor and saying, I just totally blew off my medications last night? You're going to be scared you're going to be yelled at. If you're calling to tell people that You're feeling some kind of side effects. Well, you might be deemed a hypochondriac. You could be deemed as being complaining, being challenging, being disrespectful, because I don't know about all of you, but I grew up where physicians, teachers, police officers, they're up here, and rightfully so with their education, but we put them up here with such high esteem that you just do what you're told. That's how it works. We don't want to be embarrassed. We don't want anybody to feel ill about us, so we just keep our mouths shut. And it's really essential that the communication and trust be improved between the patient and the physician in order to have effective medical care. So the healthcare journey, and that's what we're talking about. The healthcare journey encompasses all aspects of your healthcare. This can actually be from the ease of finding a healthcare provider. We would all like that to be a little bit easier, I'm sure. The ease of scheduling an appointment. I don't know about you, but there's nothing like calling a doctor when you have a problem and they say, I can see you in August. Well, in August, my foot would have already fallen off, so that I can't do that. The empathy and patience of staff. Everybody's being pushed to their max right now, so I try to be super sugary sweet when I call. Can you please, oh please, give me an appointment? It's hard. You want empathy of the staff. This is the first beginnings of that relationship with your physician. We want to know how the exam experience and the treatment plan are going. We want details. We want that experience to be simple and easy. And follow-up care. Why are we doing this? When are we doing this? Where are we doing this? How am I doing this? Paying the bill is even part of your healthcare journey. We want ease of being able to pay the bill. And I don't know about you, everything's electronic. I just feel very electronically disabled nowadays. I can't figure out where things are and the portals and QR codes. All right, so the easiest way to make this journey more effective is to learn how to ace your healthcare journey. And I realized this when I was thinking about my relationship with Dr. Udelman. What have I done with my own physicians? And I did what we talked about on that checklist. I accepted what I was told, and I just did it. And what I realized is maybe what I need to do is make it more like Match.com, which I was successful at. I found my husband on Match.com, but maybe I need to think about, what do I need to be the best patient I can be, the most compliant patient that I can be? What do I need from my physician in order to do those things? It's just like any other type of relationship you have. So when you're looking to ace your healthcare journey, you're looking to advocate for yourself, which means speak up for your wants and your needs. It means speak up for the specialty of your treatment. So we're thinking about this in terms of not only patients, but physicians, and I'll get to that in a minute. C would be communicate. You need to figure out how best to communicate with your physicians. Me, I like cell phone numbers. I don't get them all the time, but I like them. But what I like to do is say, how's the best way I can reach out to you? Do you want the portal? Do you want an email? Do you want me to leave a message? I might not like the response, but at least I know the best way that we can communicate with each other. And educate. Educating your physicians is so critical. I am not going to be compliant if you try to tell me I have to take my meds 3 times a day. I'm not like some of my friends at the table that have alarms that go off. That's not going to work for me. I need it to be simple, very easy. I also don't want to be tied to my blood pressure cuff. So I was very, very honest with my physicians based on my lifestyle and what my needs and my wants were so that we could create this healthcare journey together. So in order to have this successful partnership, the common good must be for the physicians to help the patients ace this healthcare journey. The physicians can ace their part of it as well. And that's because they should be speaking on your behalf, right? The physicians should be acing to other physicians. They should be talking to other members of the team, advocating for you, communicating for you, and educating other physicians about your condition, about how you live your daily life, and what your needs are. The last thing that we need, while we have all of the stress knowing we have a scan or knowing we have a new diagnosis, is to start chasing down all of the physicians on the team. This physician said this one said that. It's really helpful to have a physician in your corner that can help you ace this healthcare journey and help it with you. This is not a power struggle. It's supposed to be a power balance. So this is kind of what it looks like visually. So you're the patient, you're communicating and advocating with your clinician, who is in turn communicating, advocating, educating to the patient. And now we're also doing it with our clinicians, but they're doing it with other clinicians. And then I thought, okay, if I'm doing this with my own physician, how can I do this as a patient leader or in the community? And I realized if I, as a patient leader, can communicate effectively and advocate for the community and educate with my clinician, Ben Udelman, for instance, or any of the other physicians that I interview and I work with, well, then other patients are going to see me have this ease talking to the physicians. They're going to see that it's easy for me to just tell them like it is, tell them the questions I hear that the community members are asking, and get the information presented in an easy way to understand. And then hopefully they take that information back and they learn a little bit from the community. I will say that after talking to my GI doctor, because not only do I have aortic disease, I have Crohn's disease, I found out that they started shifting the way that they handle interacting with their patients. They seem to be, they feel, one of the worst offenders because there's such an uptick and rise in colon cancer. And we can assume that maybe it's because nobody wants to talk about what comes out when you go to the bathroom, right? Nobody wants to talk about any of that. And so what happens is we don't share what we're feeling physically, we're embarrassed, and then there's repercussions that end up sometimes being paid. So what they're doing now is they're calling patients at home, and they're having these conversations about management, treatment, diagnosis with the patient in their comfortable environment. They're also, when they're talking with them in the office, are no longer having all of those conversations in an exam room. They're moving it to their actual office, which makes things a little bit more comfortable. It's not so sterile. It's not wearing the white coat and the stethoscope. It's becoming more peer-like, which is what Ben and I did. I mean, look, Ben's only 1 month older than me, and it still counts, but we're basically like peers. And I realized if I can do this with my personal physicians, I can do this with the community and just become comfortable in sharing who I am. And I know that some people, they can't hear all the details. They don't want to see all the visuals. They want it to just be, tell me what you need me to do and I'm going to do it. And that's an effective communication tool. Even though it's different than mine, it's still going to be a two-way street for success. So I hope you take this back. I hope maybe you think about it a little bit, see if it resonates with you. This is one of our big initiatives for 2025. Thank you for letting me share it with you. I think everybody will have that two-way street for success if you learn how to ace your healthcare journey.
Thank you again, Karen. At this time, I would like to introduce Dr. Joe Jensen from the Metropolitan Heart and Vascular Institute. He will be talking about an introduction to devices and data. Joe Jensen is a general cardiologist at the Metropolitan Heart and Vascular Institute with a primary interest in prevention of cardiovascular disease. He attended the University of Notre Dame and medical school at the University of Minnesota, completing his internal medicine residency at Abbott Northwestern Hospital, being chief resident in his final year. Minneapolis Heart Institute and Hennepin County Medical Center were his home for the final 3 years of his training in cardiology as a cardiovascular disease fellow. If he wasn't busy enough, he took a slight detour working on 2 startup companies during his medical education. Joe now lives in downtown Minneapolis with his wife and 8-pound Maltese Yorkie, Louie. Thank you, Dr. Jensen, for serving the great state of Minnesota and sharing your knowledge of how to use technology and devices as tools within our healthcare journey. Please welcome Dr. Jensen.
Hi, everyone. Thanks for the great introduction. Really appreciate the opportunity of being here. And I'll just dive right in. Time is a little short, but we'll make it work. So as I continue in my early career as a cardiologist, I find myself referring to the foundation of our practice, guidelines. And these important documents are endorsed by associations such as the American Heart Association, the American Diabetes Association, and they seek to standardize optimal care. And so as I continue to look at these more so now than I even did in training, I see these particular phrases that keep popping up more than ever before. I see things like optimal lifestyle habits. I'm sorry, it's a little small up there. Non-pharmacological therapy, behavior changes. These are class 1 high-grade recommendations in our guidelines. Again, the foundation of our practice. It's amazing that these squishy topics were really never covered in medical school, residency, cardiology fellowship, and beyond. There's hardly enough time to digest these bulky evidence-based guidelines, much less make time and room for these less scientific topics, at least so I thought. In my search to uncover exactly what these phrases meant, I came across Life's Essential 8 by the American Heart Association. And these are what they identify as key measures to a healthy lifestyle. And we can see these here. We're talking about things like healthy eating, increased activity, blood sugar management, weight management, lowering cholesterol, blood pressure management, smoking cessation, and sleep. I find it ironic that we as cardiologists, primary care doctors, endocrinologists, nephrologists, advanced practice providers, nurses, we hardly have the time and the training to understand these simple yet complex topics ourselves, much less have time to address these with patients. To sum this up as succinctly as possible, we are not good at this, nor do we have the time. So who could possibly step in to address these essential 8 lifestyle habits, key measures to a healthy lifestyle that impact literally everyone alive? And that's industry. There is no way a target market this lucrative could be passed up. So a quick show of hands. I'll ask for participation a couple times during this presentation. Who here owns a smart wearable device? A watch, a ring, a scale, whatever it is? Okay, all right. So a little bit higher, we're higher than normal, which makes sense in this audience. About 1 in 5 Americans own and use a smart wearable device. The market is already large and really is expected to grow exponentially over the next few years. And even in the last 5 years, we've seen it grow from a $15 billion industry to a $70 billion industry, 5 years alone. So it's our job as care providers to understand what's out there, what it means, and start to think about how we integrate this data into our own practice and ultimately our own lives. And so using this Essential 8 as a framework, I'll give a brief introduction and overview to some of the most commonly used devices on the market today. And it turns out that these seemingly simple devices are actually backed by both basic science and outcomes data. So to jump in here, this is a PDF and infographic from the Essential 8 from the American Heart Association, talking about exercise, talking about moving more. Why is it important? Well, it turns out that physical activity is inversely correlated to cardiovascular outcomes, meaning the less you're physically active, the worse you're going to do. Inversely related. And so let's look at the data here. You can see these 2 curves on the left and right here. It's okay, it doesn't have a pointer, but we're looking at big things. We're not just looking at little things like whether or not someone has a nosebleed or a hangnail or something like that, which we can do sometimes in studies. That's a little facetious, but that's beside the point. We're looking at all-cause mortality, people dying. And so if you look, the curve kind of slopes down and to the right. On the horizontal axis is the number of steps per day. The more steps per day, if you get up to the far right side, that's 14,000 steps a day. That's a lot. Your risk for dying is cut in half. These are huge deals. And same thing for incident cardiovascular disease, both fatal and non-fatal. The more steps you take, even starting from 2,000 steps to 4,000 to 6,000 steps, you're benefiting yourself. So it doesn't take much either. What's interesting about these graphs is we even get to 4,000 steps a day, and that makes a significant difference in your all-cause mortality. So why does this happen? There are a couple things that I want to talk about, some semi-scientific topics. I promise we'll get through it together. The first thing is called heart rate. Obviously, the amount of times your heart beats per minute. And it turns out that your resting heart rate really matters. The higher your resting heart rate is in the morning when you wake up from sleep, the worse you do. And so if your resting heart rate is 100 beats per minute, you're going to do not quite as well as someone whose heart rate is below 70 beats per minute. That's kind of the cutoff here. So the other thing that's slightly more complicated, I'm going to simplify it as much as possible, is called heart rate variability. And actually seeing this graphic here kind of gives me nightmares from medical school. There's a reason why I didn't go into neurology, but here we are. We've got the parasympathetic nervous system on the left and the sympathetic nervous system on the right. The way to think about it is parasympathetic nervous system, rest and digest. The sympathetic nervous system, on the other hand, is fight or flight. Both of these systems play a tremendous role in our overall health, but specifically related to our heart. And so heart rate variability is the physiologic variation in duration of intervals between beats. So your heart isn't actually like a metronome. It's not beating on the same interval every single minute. There's actually a little bit of variability between beats, and that's what this heart rate variability is. This is the other slightly bigger part of audience participation here. So I want you to find your pulse, either in your carotid on your neck, which is probably easiest, or your radial on your wrist. We're going to do two things. This is also helpful for me too. We're going to take a deep breath, and then we're going to breathe out while feeling your pulse, okay? We're going to do this together. Big breath in, and then a breath out. I won't call on anybody to see what they notice, but I'm going to talk about what you just witnessed is physiology in action. So when you inhale, your diaphragm contracts, your intrathoracic pressure lowers, air comes in, more blood returns to the heart, those chambers stretch, that triggers the baroreceptors. You don't need to remember all this, but your heart rate increases as you inhale. The opposite actually happens as you exhale. Your diaphragm relaxes, your chest cavity decreases, there's less venous return, less blood coming back to the heart, you're not suppressing the vagal tone, and your heart rate decreases. So you can do it again, but those are essentially the sympathetic and the parasympathetic nervous systems in action. So we just learned together that heart rate increases with inspiration and decreases with expiration. And higher heart rate variability is better. That means you have more parasympathetic input, more rest and digest, less fight or flight. This is a list of a bunch of studies that show that people with higher heart rate variability do better overall than people with low heart rate variability. But it turns out this metric isn't just for the sick, and in fact, elite level athletes are using heart rate variability as a metric to tell them when they should really push themselves. When they wake up with a high heart rate variability, those are the training days that you really want to go all out. Whereas if the opposite happens, where your heart rate variability is lower than it normally is, that might need to be a rest, recovery, flexibility, mobility day. Athletes have actually done better when they train based on their heart rate variability than if they don't train on their heart rate variability. So why does this happen? There's a bunch of different kind of pathophysiology, physiology things that happen here, but essentially higher heart rate leads to more stress, higher blood pressure, increased oxygen consumption, and lower heart rate variability can lead to arrhythmias and other negative cardiovascular outcomes. The good news is that we can do something about this because increased activity levels can actually lead to a lower resting heart rate and a higher heart rate variability. So there are a lot of tools for this that have been developed over the years. This is a pedometer. This is kind of tracking from where we came in 1760. 1760 was the first pedometer. We have the first pulse oximeter measuring somebody's oxygen level in 1935. We have the first Fitbit product in 2009, and then the first Apple Watch with an EKG in 2018. Now, there was an explosion of devices between the years of 2011 and 2015, and I just have to do this. This one is near and dear to me, coming out May of 2013. It's the Fitbit Flex, and I had the bright idea over 10 years ago now that it'd be a good idea to wear on my wedding day. So my wife wasn't exactly thrilled with the fact that this showed up in all our pictures, but I will say, to this day, I'm still talking about it, so I think I made the right decision here. She may or may not agree with me at this point, but it's there. So I've got a long history with these devices. And so how does this work? And again, this is a little bit above my pay grade. I'm not a mechanical engineer, but there are two ways this works: a triaxial accelerometer, which works in the XYZ plane, and a gyroscope. And essentially, those form the 6 degrees of freedom. These are all microelectronic devices, circuits in all of these devices. And you combine those with GPS, you get a lot of people that are a lot smarter than me programming these devices, understanding what happens in running, what happens in sleeping, what happens in all of this, so we can write the software algorithms to get all of that raw data from those sensors and then have these devices tell us, are we exercising, are we sleeping, are we rowing, or whatever. Pretty cool stuff. And so how does this work? How do these devices work? And there are two different ways that they work primarily. Pulse oximetry, which is what people are used to, especially in COVID times, of checking somebody's pulse. You see that red light, and it's looking at the capillaries. And then there's this other one called photoplethysmography. That's the last time I'll say that, PPG for short. And so what it does, it actually looks at blood volume changes in microvascular, really, really small blood vessels. And all devices use the PPG technique, all the devices that I'll talk about today. And then, of course, the last way to do it is an EKG. People are familiar with the 12-lead EKG that they might get in a physician office, but there are devices like the Apple Watch and the AliveCore that also do this as well. And it's important when I talk about these devices that they've all been tested against the gold standard. So here are 3 graphs. The whole point here is to show that an Apple Watch, a Whoop, and an Oura Ring, I'll talk about all three of those, directly correlate with the gold standard of EKG for heart rate monitoring. They're all very, very accurate, most notably Whoop. The more narrow the bar is, the more accurate the device is. So from a heart rate standpoint, Whoop remains supreme. This chart again shows that a lot of these devices have been studied and continue to be studied in long-term population studies looking at outcomes that I've kind of talked about a little bit so far today. So they're continuing to be used in studies as we go forward. In fact, this one in particular was published in the New England Journal of Medicine, and it actually looked at 420,000 patients over 8 months using an Apple Watch to detect atrial fibrillation. And it actually is quite sensitive and quite specific. It's not perfect. I see patients in clinic that bring in their Apple Watch data not infrequently, and I have pretty good success with it. And actually, it's a really good tool for those people who have arrhythmias very infrequently that we might not catch otherwise. So really important stuff happening in really big medical journals. And so to dive into these devices just a little bit, people are probably the most familiar with Apple Watch. And so the nice thing about Apple Watch is you can get a bunch of different apps on the same device. A calculator, you can get your sleep tracked, you can get your activity tracked, you can do all this stuff and more on an Apple Watch. And you typically pay for the device up front. You might have subscriptions for the individual apps that you use, but it's all in one place. And the nice thing about this technology too is it's a single lead EKG, as I mentioned, so you get pretty good data from a heart rhythm standpoint as shown by that New England Journal of Medicine article. Whoop is a little bit different, and I purposefully included pictures so you could get a feel for the flavor of their marketing, what their vision is, what their mission is, and in this case, Whoop is here to unlock human performance. So you see a lot of high-level athletes using these. There's a partnership on the PGA Tour. People will argue with me if golfers are high-level athletes. They definitely are, so there's that. And this device is interesting because it stays on your wrist, and you can charge it on your wrist all the time. So this device can essentially be with you 24/7, 365. You got to take your Apple Watch off to charge it at this point. So that's kind of an interesting feature with Whoop versus others. All three devices do essentially the same thing. And on the left, their marker of activity for Whoop is called strain. And so you get a strain marker for how much activity you've done during a period of time, a day, week, month, year, whatever it is. They all also track sleep. That's the middle graphic here. The stages of sleep, how many times you woke up, if you exited the bed, all of that stuff is available on these devices. And then finally, your recovery. It all feeds together. So it's how much activity you get, how much recovery sleep you get, and then your recovery score, which is that every single device has their own proprietary algorithm, but it tells you how ready you are to attack your day in whatever you do. So that recovery score or readiness score for Apple Watch or readiness score for Oura Rings, use all of that data to come up with your readiness for the day. This is probably my favorite slide, most impactful slide. So if you take anything away, I think this is super cool. So this is an example of what a workout would look like on a Whoop device. And so you see all the different up and down markers here. That's your heart rate. That's this person's heart rate. And so at the bottom actually is 100. So this whole time the person's heart rate is between 100 and 150, sometimes creeping up to 175 before it goes down. This whole workout lasted about an hour. Again, heart rates, probably the average was 130, 140, 150, so a good workout. This wasn't a workout. This was actually a medical resident taking care of a very sick patient in the ICU. This isn't somebody that's doing chest compressions, jumping on the bed, doing anything like that. This is somebody in the room actively taking care of a very sick patient. And I just think that data alone is so powerful and so important, not just for us as physicians, as care providers in the healthcare industry, but really strain and stress on a daily basis is so under-recognized really in so many professions. And so to be able to see that data here in what would actually be a really good workout for an hour with your heart rate elevated to 140, 150 was just somebody taking care of a very sick patient. This one is interesting too. Whoop is a monthly membership that you pay for. There are a bunch of different things and promotions that they do along the way, so slightly different pricing model than the Apple Watch. Aura, you'll notice everything is softer here. It's a little bit more gentle. Their initial focus when they released was about sleep. And so their priority is sleep, they are exceptional at sleep, and they've gotten better over the years at everything else. And so again, the messaging is just very different. Sleep Tight with the industry-leading sleep tracker. There have been specific studies in combination with mattresses to measure sleep. And then the mattress companies use the Aura data to say, hey, sleep on our mattress, I can prove to you that you're gonna get better sleep. And they do. Same thing as the other devices. The rings can track exercise as well. And again, they look at sleep, they look at activity, they look at recovery. The pricing is a little bit different for the Aura Ring as well. You have an upfront $250, I think their new generation, or $350, excuse me, is about the same. And then depending on how many features you want, you can pay for an extra monthly fee. This device, KardioMobile, is pretty interesting and one that I find myself recommending to patients pretty frequently for those infrequent arrhythmias and those people that might be a little bit less tech savvy. This device is really cool because it's a single lead EKG device that's the size of a credit card. Carried around in your wallet, if you start to feel palpitations, dizziness, lightheadedness, whatever, you take it out, you put your 2 fingers on those silver areas, and you get a single lead EKG. That shows if it's normal rhythm, abnormal rhythm, and I actually have had multiple patients that I've diagnosed with atrial fibrillation based on this data alone that we otherwise wouldn't have captured. And then we can make the appropriate medical decision making based on that information. This is a little bit different as well. They're pretty affordable. The not credit card sized one is about the size of this remote clicker. I think that one starts at $80. The credit card one is about $100. And you can pay a yearly fee as well if you want specific interpretations of your strips by a cardiologist, or you just bring it into your cardiologist if they're familiar with it in your routine visits anyway. So, which one is best? What do we do? What do I recommend to patients? And it's interesting because, again, in I think this was the Journal of the American College of Cardiology, they actually directly compared these devices. And what we looked at in this case was the Apple Watch versus the Samsung Watch versus the Withings Watch, the Fitbit Watch, and then finally the AliveCor device that we looked at. And overall, the best performing device to detect arrhythmias was the Apple Watch. So if someone is interested in specifically looking for arrhythmia, I point them toward an Apple Watch or that AliveCor credit card device. If we're talking about overall health, wellness, stress, rest, recovery, all those essential 8 markers that are important, then I think Apple Watch, Aura, Whoop are kind of individual preferences at that point. You can't really go wrong with any of them. And so overall, what we know is that decreased physical activity, increased heart rate, and decreased heart rate variability, they all lead to higher levels of mortality. And the cool thing about this now is with these 3 devices, I can actually get personalized, actionable data from that patient sitting next to me in the exam room. It's not like this. This is a picture of what we have. It's called the pool cohort equation, where we look at a population of people. We plug their blood pressure in, their cholesterol in, their age, their race, whether or not they have diabetes, whether or not they smoke. And we have calculators. That's the best kind of risk assessment that we can do. Those are based on population studies, massive amounts of people. These devices allow me to look at the data of that exact person and then make recommendations for them based on their own individual actionable data. And so to wrap things up, I'd like to peer into a crystal ball in an attempt to see the future. I can see a clinic. Maybe it's a building, maybe it's a room within an existing clinic, and maybe it's not physical at all. Maybe it's a virtual clinic database. And I think that this clinic will teach patients how to use these devices and collect actionable data from a variety of them. Maybe this is some wild fantasy, but I truly doubt it. And all of these devices will lead to better, more individualized care for our patients with truly actionable data. And together with industry, we as healthcare providers can build on this essential aid, and we can build that better future both for our patients and for ourselves. Thank you.
Thank you again, Dr. Jensen, and I do have to put in a little plug for Whoop. I was a college athlete myself and had a Whoop and loved it, so If you're looking for something, WHOOP is great. Next, I'd like to have Dr. John White come to the stage. He will be talking about symptoms to solutions, partnering with your clinician for heart valve health. Dr. John White is a physician, author, and chief medical officer at WebMD, where he leads efforts to create meaningful change in public health. He plays a pivotal role in evolving digital platforms to connect people to care, and author of multiple books which encourage people to take control of their health in a positive way. Previously, Dr. White served in leadership roles at the U.S. Food and Drug Administration, Discovery Channel, and the Centers for Medicare and Medicaid Services. A board-certified internist, Dr. White continues to see patients and holds an MPH from Harvard University. Thank you, Dr. White, for joining Rock from the Heart and sharing with our audience ways to navigate their health and healthcare in the modern era. Please welcome Dr. White.
Well, thank you for that very kind introduction. And I really have enjoyed the conversations that I've been hearing, especially from Karen and Dr. Jensen. And I have to tell you, really the theme that they talked about that I'm going to talk about is empower yourself with information. Advocate for yourself as a patient. Ask questions. That's really what we need to think about as we think about heart disease and heart valve disease. As mentioned, I'm Dr. John White. I'm the Chief Medical Officer at WebMD, and I'm also on the Board of Directors for the Alliance for Aging Research. And some of my colleagues from the Alliance are here with me today helping put on this great conference. And they've been supporting Heart Valve Disease Awareness Day, which is always held on February 22nd and started in 2017. And I'm delighted to say I've participated in the majority of them, not all of them, but most of them. Because like many of you, I'm interested in heart disease. I'm interested in how we educate patients. I mean, I feel like I might need to get a whoop soon. I don't know how you feel, but data is important. And that's what drives decisions. So it's really a privilege for me to be with all of you today, and I'm going to stay through the weekend because when we talk about heart disease, we talk about valvular disease or arrhythmias, we have to remember that with all of these diagnoses, there is a loved one behind this diagnosis, a shared experience, and we really need to keep that in mind. So what I'm going to talk about is heart valve disease. Remember, the heart has several valves in terms of how the heart pumps. And many people may not be aware of valvular disease, but it impacts more than 1 million Americans. 11 million Americans are currently with heart valve disease, and 25,000 people die from heart valve disease every year. And one of the most common forms, you might have heard about it, aortic stenosis. There are some other types of conditions. You might have heard mitral stenosis or aortic regurg. But when you think about it, it affects nearly 1 in 10 adults over the age of 75. And we put out these numbers, but remember, behind these numbers are people. And we can't forget about that because they're our friends, our spouses, our loved ones. And while these are big numbers, 11 million people, 25,000 people die every year, there's really an underappreciation and an underdiagnosis of valvular disease. And I would say these numbers are probably even bigger. I wish we had a Fitbit, an Apple Watch, a Whoop that could detect valvular disease, but we don't. I am going to tell you how we do detect it, but that's especially concerning when we think about underserved areas, when we think about minority populations that often don't get as good care, and that also is in diagnosis. So often the symptoms, you may say, well, Dr. White, how would I know if I have valve disease? Because some of those symptoms can be fatigue, right? You're tired. You might have some shortness of breath. You may think, I'm just getting older. I'm just slowing down. And you don't think, hey, maybe I need to get checked. And that's what we want to change. Now, for those of you that have gone to the doctor lately, maybe the primary care physician, not the orthopedic surgeon. I'm not sure if they still have stethoscopes. I don't know if any of my ortho friends are here, but when was the last time at your last appointment, show of hands, that the doctor actually placed the stethoscope on your chest and listened to your heart? Okay, so not everyone, right? And a lot of doctors aren't doing this, or maybe they've done it once, they don't feel like they need to do it again, or that's not what you came in for. But that's really the way, the first step in detecting valvular disease, a simple stethoscope exam. And sometimes people think, well, I've never had this thing called valvular disease. Do they need to check? And we know that as we get older, valve disease increases because our valves may not have as good function, they may get stiff. So we really need to check for what we're calling a murmur, this unusual sound that we hear by the way that the heart is pumping. And that can be one of the first signs of trouble. And unfortunately, as I mentioned, many healthcare professionals, they've moved away from doing it. They're busy, they have a lot of things going on. That's not what you came in to talk about. And that's a concern because sometimes those symptoms can be overlooked. And we have a simple test to check for it. And while we have done a bit to improve awareness over the last 9 years, the fact is that when most people think of heart disease, what do they think about? They think about heart attacks, right? And that is concerning, and we need to do better at managing heart attacks, and we've done better. But the same is true for valvular disease. One survey found that as many as 3 out of 4 Americans, 3 out of 4 know little or nothing about heart valve disease. How many of you have heard of heart valve disease? Have you heard of aortic stenosis or mitral stenosis, aortic regurg? And that's not a bad number, but we should have everyone. Everyone here has heard of heart disease. Everyone here has heard of atrial fibrillation because we've done a lot to educate folks. But we need to do more. We can change that. We can take steps individually as well as a community. And that's why it's great to see so many people together to get better care, to get better outcomes. But it starts, with diagnosis and advocating for ourselves. And some of you may think, well, Dr. White, and I think of Karen's comments, people want to be a good physician, a good patient. They don't want to challenge the physician. And you might be thinking, can I say to the doctor, maybe you should listen to my heart? Sure, you can say that to the doctor. And if the doctor gets offended by you saying that, you should think about getting another doctor because you need to be your own advocate. You really need to empower yourself. Now, some of you are laughing. I'd love to hear what you're talking about after this, whether you really can say it to your doctor, but you should be able to, right? You need to advocate for yourself. And if your doctor has never listened to your heart and it's a primary care physician, I would argue there's a little bit of a problem there. So really, the key to successful outcomes, as I've been saying, is early detection and treatment. And that's really what we want to think about. We do have new research that's making the case for early intervention. If you have severe aortic stenosis, and even if you don't have that many symptoms, we know that early intervention is going to lead to better outcome. And we've had multiple studies that have shown this. Multiple meta-analyses, which is an analysis of several studies, have shown that early intervention, and we see this with a lot of diseases, is key. And that's what I want you to be confident of, that we have better solutions nowadays too. We didn't always have that. It always had to be this open heart surgery. You need your chest cracked to repair your valve. Now we have different procedures and different strategies. So that's always important to know, that if you get the diagnosis, what are your options? So this is the point about your voice matters. And you always want to go to a conference like this and, what are your take-home messages? What are you going to learn? What are you going to tell your friends? I'm going to look at Whoop and maybe a few other things, but what are you going to learn from that guy, from WebMD and the Alliance that told you about heart valve disease? And at WebMD, our motto is that better information leads to better health, right? And that's what I want all of you to have, is good information. And I want you to advocate for yourself. I want you to advocate for your own health and know your medical history. Because with many diseases, there are some genetic components. And sometimes it may feel troubling to ask relatives, what did Uncle Joe have or what did Aunt Mary have? But if you do have a family history of valve disease, that's important to know because screening is going to be even more important for you. And remember, a lot of times we lump all heart disease into heart attacks when they're not. So that's the first thing. You need to be proactive with follow-up and ask questions. I loved Karen's point when she said you want to call the office and you want to be nice to everyone. And I still see patients, and I said to people at my table, if they answer the phone when you call the doctor's office. So I get it. It can be challenging. And you want to be nice, but also, sometimes the squeaky wheel does get the grease. I'm just, pointing that out. So you want to do as, other speakers have said, you want to do those ABCs. You want to be proactive. You want to go to sites like WebMD, and there's lots of other good sites to empower yourselves with the questions that you should ask in terms of, might I have valve disease? Why am I more tired now than I used to be? Why do I have swelling, in my legs? We know that it increases with age. And I don't want you to think, as I see many patients that do, that think it's just a normal part of aging. Sometimes it is an important part of aging, but other times it's not, and it's valvular disease. And if you don't ask the questions and don't bring it up, then you'll never know. And I'm going to tell you something that a lot of doctors don't like, but I would do it when I would go with my mother to the doctor, and I do it to myself when I have questions. You bring your list in, or you have it on your phone, and you don't leave until you get all your questions answered. Even when the doctor wants to, put their hand on the doorknob, you just stay seated. What do? They come back in. If they don't come back in, then they're very rude, and you really should find someone else. But you want to ask your questions. That doesn't mean that you need to have, a list of 20 questions for that visit. That might require another visit. But you do need to educate yourself prior to your doctor's appointment. And as I said, there's lots of good resources out there. And that's about being informed and doing your own research. And there's a lot of great community sites online as well in terms of Facebook and other pages that can give you more information. And we know that shared decision-making is going to improve health outcomes. And that's what's really important about it in terms of if you get the diagnosis, you want to have a good outcome. So in terms of, as I mentioned, a lot of places on the internet you want to get information, and this is just a little bit about, we're running a little, short on time about how the heart works in terms of those different valves and how they could have an impact. But those are some of the things I want you to think about as to how you can empower yourself with more information. Because your relationship, I'm joking, but your relationship with your healthcare provider, your primary care physician, perhaps a cardiologist, it really is about a partnership. And that might be a new way of thinking for many people. It was mentioned, early on that we hold teachers and doctors and police officers at this very high level. Honestly, I wish that was true. It's not always true nowadays, but you're your own expert. And that's what I always say to patients. If you feel that something is wrong, you know your body your best. If you're having trouble breathing, you're feeling fatigued, then you need to get it checked out because something might be wrong. And when it comes to valvular disease, you have to have someone listen to your heart. That's the beauty of it. That's how we find out. And I'll tell you, sadly, we're not teaching as well as we did in the past about using the stethoscope and listening to the heart. And luckily, we have more, diagnostic tests such as an echocardiogram that you would use to know for sure. But these are the things that you need to be thinking about. And what I love is that there is a sense of community. There is advocating for others when we talk about valve disease. Because when you talk about your experience, whether it's on social platforms or old school one-on-one today, as you can be at tables, that's going to empower others and influence others also to share their experiences or also to think about their own health and their families members' health as well. You know, you want to have conversations with your family and friends. You want to talk to your loved ones, and you can tell your parents or your spouses. I heard Dr. White from WebMD, and he told me to go with a list of questions and not to leave this office until all of them are addressed. But that's what's going to empower you, because your participation, and even more so advocacy, can help save other people's lives. Because there's a lot that needs to be done at the doctor's appointment. There's a lot of research that still needs to be done. We need to advocate to address valvular disease, to really figure out how we screen people more effectively. How do we educate patients, but how do we educate clinicians? Because the other point I want to emphasize again, you may say, well, I've never had valvular disease. I hear that a lot of times from patients. Or, you know, they put a stethoscope on years ago. I didn't think I needed to have that done all the time. But if you're having a change in symptoms, or you're having some subtle symptoms and you've educated yourself, then that's an important step. And you have to ask your doctor about it. So that's why it's so important, you know, to empower yourself. You want to get involved, you want to visit valvediseaseday.org. For those that you are on X or, you know, Instagram, you know, we have the hashtags that I want you all to think about and promote. And as I said, I'll be here, you know, for the next few days. I'm always happy to answer questions one-on-one as well. So it's all about empowering yourself, learning the signs and symptoms of valvular disease, making sure that your doctor listens to your heart and checks for murmurs, and then if you do have one, learning what the options are for you or a loved one. And with that, I think I might even have given you back an extra couple of minutes. So thank you very much.
Thank you, Dr. White. Next, we have Maureen Rose Doran from the Penny George Institute for Health and Healing. She'll be speaking on an integrative approach to your well-being. Maureen Rose Doran is the lead nutritionist dietitian at the Penny George Institute for Health and Healing. She specializes in integrative nutrition, a science-based food is medicine therapy for prevention and treatment of chronic diseases. Maureen also has a master's degree from the University of Minnesota in health and well-being coaching and training in mindfulness-based meditation to help people achieve the changes they want to make for optimal health. A warm welcome to Maureen. We look forward to learning how simple changes within our lives can make big impacts on our health. Please welcome Maureen.
Well, my goodness, this is such an impressive event. And I really want to thank Amy and Pete, first of all, for putting together this incredible organization. And it's really grassroots, which is what Dr. White has been talking about and what we talk about as well, which is advocating and empowering ourselves so that we can really be who we've come here to be in our best way. I want to also thank you, all the volunteers, thank you, who really made this event come to life. And of course, Megan Holmes, I don't know if she's in the room right now. Thanks to Megan, that's why I am here. Megan did some volunteer work at the Penny George Institute for us, and you'll see a little bit of her work in a moment. I think how I'd like to begin is that you already know why your health is so impactful. You know whose lives you touch. You know what you need to do, and a lot of that discussion has come before me. Oftentimes we know what we need to do, but maybe we have trouble with the how. How do I do it? How do I incorporate exercise into my life? And that's where places like the Penny George Institute here in the Twin Cities can really come in to play. So as you could see here, 80% of our health happens outside of the doctor's office. 80%. And again, that's why organizations like this are so important, these grassroots efforts, because it's really what we do outside of the hospital surgery room and what we do outside of our doctor's clinic that can really have a very large impact on our health after we've been patched out or after we've been given our medication. So 80% happens. And again, families know oftentimes, thanks to you all, thanks to this organization, the basics surrounding, your disease. And they are learning how to become the best advocates for their health. And we at the Penny George Institute really understand, and we have the same philosophy when it comes to advocating for oneself. And ultimately, and this is so interesting that this topic this afternoon seems to be empowerment, seems to be self-care. A word that we often use is agency. And so, as I say, we are founded on the same kind of principles as this organization has been founded. We at the Penny George Institute really do understand what it's like. And we advocate for you advocating for yourself, and ultimately the power of your self-care. So we were started philanthropically, like your organization was started as well, by Penny George, who is the wife of Bill George, who was the CEO of Medtronic. And Penny George herself had breast cancer, and she was at Abbott Northwestern Hospital, and she's a psychologist by trade. And so she really understands that it's not just the body, but it's also the mind that's important to tend to when something critical happens in your life, like cancer or aortic disease. And so while she had excellent care at the hospital, she came away thinking, I think we need to be treating the whole person a little bit better than just the disease. And so as a result of that, she started what we call the Penny George Institute in 2003. And what we really do is we partner. You've heard the word empowerment. You've heard the word advocates. We partner with you so that you can be the best you can be. And a couple of years ago, in fact, we had proof of concept for several years with our topic with our field of integrative medicine. And we are now a specialty group, just like cardiology, just like nephrology, just like orthopedics, just like dermatology. So it's important to know that this field of integrative medicine has really come into its own and has really proven itself to be of value in terms of the health and healing process. So I also want to point out, though, that it's not an either or. It's not either conventional medicine or integrative medicine, and I'll explain integrative medicine in just a minute here. It's a yes and, that integrative medicine essentially supports the work of conventional medicine and expands on it. We don't want you to do acupuncture instead of having surgery. That's not why we're there. But acupuncture can certainly help you heal from surgery. Acupuncture is proven to help you with the anxiety that surrounds surgery, and that's why we exist. So it's a yes and. And so what is really integrative medicine? Well, it's as I mentioned, it's a healing-oriented medicine that really emphasizes the relationship between you and your doctor. We have much longer appointments. And typically, of course we're going to ask you, what's the matter? How can we help you? But we also make sure that we ask you, what matters to you? Because if we can tap into what matters to you, it's going to be easier for you to take on those things like exercise, like maybe healthier eating, like, stress management. And so we work pretty hard on that, identifying what really matters to you in your life and then building on that. And so we are informed by evidence. We use all kinds of therapies, as you've already heard me mention: acupuncture, nutrition. We have doctors and doctor of nurse practitioners who work in the newer field of functional medicine. We have massage therapists. We have aromatherapists. And we do have the largest inpatient, I haven't even mentioned the inpatient unit yet, or not unit, service, because we're all over the hospital. And these things can really make a difference in terms of your healing process. So it's definitely a field that is up and coming, and really, to a large degree, we're informed by what patients are looking for. So we became a specialty only because patients really felt the value of this and are demanding it through their health. So with that, this kind of gives you a little model of what we're about. But as I mentioned before, most of health and healing happens outside of the clinic. And it can be powered, it has to be powered by our own participation, our self-awareness, our care, and our attention to not only our body, but our mind and our spirit, what we eat, how we move, how we sleep, what do we do with stress, how do we manage our stress. So what we call sense of agency, which is essentially the same thing as empowerment or self-care, it means that we draw from that part in you who is ready to make changes on your own time, at your own pace. We recognize that the small changes are really the most impactful, because nothing begets success like success, right? And if we can do the small changes, then we feel good about that. And maybe we're able to do the next change, whatever that may be. So we also know that our sense of agency is really influenced by our environment, our community, our relationships. And so we recognize all of that. And we help patients navigate the dynamic interconnections of all of these things. So if you were to come to one of our clinics, we would be asking you about your sleep. We would be asking you about your stress level. We would be asking you for your story. What brought you here? How did you end up here? And oftentimes, to be perfectly honest, folks come to us when they haven't gotten the answers elsewhere. Now, clearly, this does not apply to, the aortic disease situation, because you get excellent care there. But it's these other things that might be going on. Maybe you have prediabetes, or maybe you have RA, rheumatoid arthritis, or maybe you have IBS, or, as was already mentioned, Crohn's disease, or one of the many, many autoimmune diseases, migraines, that you don't really feel like have really been addressed, or you feel like you could be a little bit healthier, but you just don't know what or how to do it. So even though this is a conference about the heart, you may have other things going on as well, that after you get the heart stabilized, maybe you're interested in looking at, wow, how's the rest of myself? What does my future look like now that I've got my heart piece under control? What about my XYZ? And so, as I say, we're really informed by evidence. And just to give you a brief idea of what it is that we might be referring you to, and within our clinics, as I say, we have all kinds of different modalities, and we talk to one another. The health professionals, we do a lot of internal referral. We do a lot of communicating about, I saw this patient for XYZ, and I saw them for this, and we put all those pieces of the puzzle together, and it results ultimately in your optimal care, we hope. And so you might wonder, where are we? We're in the Twin Cities here, but we have grown so quickly that we're now we used to be in just one location, now we're in 21 locations. In fact, we're often embedded into primary care clinics, which is really where we should be, because a lot of this is typically owned by primary care. And as was already mentioned, oftentimes your doctor doesn't have enough time to talk with you about these more lifestyle things that you could be doing. So we're involved in 21 locations. We are also in the hospital, as I mentioned before. We have a lot of virtual visit possibilities. Most of our services are covered by insurance, and I think that's a really important thing. I believe that's because we're embedded in a fairly large healthcare system, as in Alina is a fairly large healthcare system. And so we can really maximize, the insurance potentiality, I guess I would say, much more so than perhaps your corner acupuncturist or your massage therapist. And this is a good thing because it means that more people are going to be able to have more resources. And so we're basically insurance-based, although we do have low-cost retail options for those who might not be covered. And we do, as I mentioned, integrative and functional medicine, integrative and functional nutrition, integrative psychology. This is an important one because I don't know for sure if this has been the case for you, but any of you who have gone through life-threatening situations, you may have been told, wow, we made it through, you're doing okay, but maybe in your mind you're like, whoa, what just happened to me? And you have to integrate that. And we have integrative psychologists who really help with that. And so we're here for you. We also do a lot of group work because many times, as our integrative psychiatrist says, the group can be the medicine. And so when we do, for instance, preventing diabetes for people who have been diagnosed with prediabetes, and really the treatment there is lifestyle, so it's changing the way we move and the way we eat and the way we handle stress. But when you do something like that in the group can really support and help one another as they make these changes, and bring up their barriers, which could be addressed, and who knows, they could be someone else's barriers. They also bring up the solutions. So it's really group medicine is a really wonderful way to go about. So I just wanted to mention here in these few last minutes, integrative and functional medicine. I already mentioned a few of the diagnoses, but you have this in your folder. I think you have a brochure. But these are some of the things that we really work with. And they're oftentimes are more chronic things where maybe you feel like, I think I could get better, but I just really don't know how, or maybe I need something else. And so it's more of these autoimmune things and these actually common things, but maybe you just feel you can get a little bit better with them. So that's what our integrative and functional doctors do. I mentioned that we do have Chinese medicine. I think we have 36 acupuncturists on staff. They're busy all the time in various locations. And I've also listed there the diagnoses that they have evidence for with treatment. They've gotten good outcomes. And this is just not our research, it's research across the country, actually across the world. And then we actually have what's called the Live Well Center, which is, generally speaking, it is retail, and it's more like body composition. And maybe you want to work with an exercise physiologist, not just a personal trainer, because you've got your Fitbit or you've got whatever the device is, but you're really not sure what's right for me. And so our exercise physiologist can really help with that. We also do a fair amount of weight management, really holistic weight management in that group. That's where our coaching comes in. And all of this can really make a difference in terms of your own health and well-being. And then, of course, part of my area is the nutrition area. So we practice both integrative. So we do a lot of inter-referrals, as I mentioned before. If I see someone, let's say with IBS, and we start working on maybe what the triggers are in terms of their food, it might become clear to me that that person really could benefit from acupuncture. They really could benefit from seeing one of our doctors, and then we'll refer, and they may have further testing, they may have medication changes, sometimes supplements are recommended, but again, everything that we do is evidence-based. And we do a lot around stress management too, because, you know, as we all know here, that flight or fight response, it can really do damage in the body, especially if it's prolonged. And so we work hard with helping you to manage or mitigate your stress and how to respond to it. So with that, let's see if this little video with our star Megan.
We are here to support you in your health goals. Food makes a big difference in how you feel each day. We really believe food is medicine. Nutrition is important for every person's healthcare plan. At the Penny George Institute for Health and Healing at Allina Health, an integrative nutritionist can help you make lifestyle changes to lower your risk for chronic health conditions or manage current health concerns with more confidence. First, we will get to know you. Come on in and have a seat. A nutritionist can help you look at all of the symptoms that you've been experiencing, areas that might be out of balance, that we might be able to rebalance using food as medicine. Reducing pain, reducing inflammation, improving digestion, improving mood, your sleep patterns.
I want to take that next step.
Getting ready for your visit is important. We want you to think about your relationship with food and your health goals.
I just want to understand the best choices I can make.
We can use all of that information to discuss your priorities, assess your current health, review your health history, examine your food patterns, and make a plan that feels really individualized, personalized, that you're ready to put into action.
Hi!
And it is so fun to see the transformation and the changes that can happen even in a couple sessions.
I feel like I'm on the right track here to get better.
If we can help you get nutritious food and foods that you're really enjoying, we're going to help every cell in your body work better so you can enjoy all the things that you love in your life.
So thank you, Megan. I don't know if you're in the room, but Megan did a great job on that. And by the way, you have that recipe in your folder. We often get asked for that. Where's that recipe? So with that, let's see, I think we popped ahead there. With that, I really want to thank you for your time, and just know that we're there for you. You have our brochure in your folder. We are ready, able, and willing to help you, and we really wish you the best. Thank you.
Thank you again to Maureen. Next, we have a survivor story from Barbara Ablett. Barbara Ablett is one heck of a survivor. Along with triumphing over a cancer diagnosis, Barbara is the grateful recipient of an Artrivian, if I'm saying this correctly, Onyx aortic valve. She has taken great strength from her health experiences and is a mother of 3, grandmother of 4, and caregiver of a parent with Parkinson's disease. She finds healing and contentment through a love of the mountains and the outdoors. An avid hiker and backpacker mountain climber, Barbara has made it a goal to collect adventures across the world. Her motto is, "Gotta just keep moving." Barbara, thank you for sharing your strength and the courage it takes to conquer aortic disease. And welcome to Minnesota.
professional. My heart rate, or my Apple Watch is telling me my heart rate's up. So bear with me. I have to start with saying I've never done this. I've never been to a conference like this. I spoke at the Artivian meeting, but everything that everyone has been saying here is somehow part of my story. And you'll probably hear it, so forgive me if I stumble. So I'm a survivor of aortic stenosis and fortunate recipient of the Onyx valve. In 2011, at the age of 47, at a routine appointment with a new provider, I was asked, "How long have you had that heart murmur?" And my reply was, "What murmur?" This was the first time I'd ever heard mention of one. An echo was ordered, and it was determined to be just something to monitor at that time. 6 years later, in July of 2017, at another routine visit with another new provider, the murmur was still there, and it was suggested I see a cardiologist. I made an appointment for an echo and follow-up. The results then showed I had moderate aortic stenosis, something that I'd never even heard of. The assumption at this point was that it was due to the radiation I had received for Hodgkin's lymphoma in 2000. My treatment had been 4 months of chemo and 18 rounds of mantle radiation due to 3 tumors in my neck and chest. I beat it, but the radiation left me with a low-functioning thyroid for which I take daily meds. We discussed the need for surgery one day. I was told there was no need to worry about it for a long while. It would be further down the road when I was much older. For now, I had the okay to carry on with my normal activities, starting next with a 91-mile solo backpack trip in the Washington State on the Pacific Crest Trail. As far as I was concerned, I had no reason to let this stop me. I completed the backpack trip successfully, feeling stronger than ever and excited to plan my next adventure. That spring, I began to hear, I apologize, I think I'm out of order. That winter, I decided I wanted to learn about snowshoeing and do more hiking in the winter months. So I found a club and new friends of the Peninsula Wilderness Club. Snowshoeing was more challenging than I had expected, and we started at higher elevations. It's a different type of workout, but I knew I was stronger than I was feeling. My doctors all chalked it up to menopause symptoms and my thyroid meds needing adjustment. That spring, I began to hear talk about the club of a mountain climb. Mount Adams is one of Washington State's volcanoes, second highest to Mount Rainier, at 12,281 feet in elevation. I found my next adventure. It was set for the weekend after the 4th of July, and I had time to train and was feeling strong, but still had these occasional bouts of just feeling off. I checked in with my cardiologist for approval. Would I be okay at over 12,000 feet? She said she didn't need to see me, just stay hydrated, go slow, and have fun. So off we went up that mountain, and man, was it hard. My legs felt heavy like lead, and I was so fatigued, but I'd never been to these elevations, so I just thought it was something to expect. I had my first high elevation mountain summit on July 8th, 2018, with great support from my new friends. Even though I had the fatigue and feeling of heaviness, I did not have any other symptoms that I knew of. And only at my high levels of activity did I even experience this. In my everyday life, I felt normal. My energy was high. Later, I would come to realize that there had been small symptoms I didn't recognize, and again chalked up to menopause and thyroid. My next big backpack trip was a month away, so I decided to schedule my annual cardiac checkup and echo to get it out of the way. 3 weeks after my Adams summit, at my follow-up visit, I was told the results. I had reached the severe stage, which meant it was time to plan for surgery. I was in complete shock and denial. I had a hike to do, and I'm pretty sure that I stated that firmly. I was told just as firmly back that I could not go. How could it have accelerated so quickly? The cause was unknown, but I was assured that it was not anything I had done. I immediately began to research for the best medical facility to have such a huge surgery. For me, to make it my choice felt like I was maintaining control at a time when I felt so helpless and vulnerable. After lengthy research and consulting with my cardiologist, I chose Swedish Medical Center in Seattle, Washington. She put in my referral to a Dr. Glenn Barnhart, head of the thoracic department, who had performed thousands of valve replacement surgeries. I scored big time. On September 6th, I met with the surgical team at Swedish for the first time. I brought along a fantastic note taker to keep track of all the details that I knew I would forget. We discussed the pros and cons of valves, tissue and mechanical. And I learned that if I chose a tissue valve, I could fail in as little as 5 years and I would be facing another surgery. I immediately knew that was not an option for me. A mechanical valve would require blood thinners. In my active lifestyle, that was a concern. I was determined to not let this hold me back. I was then shown the Onyx aortic valve. There were a lot of technical advantages presented that I quite frankly could not understand, but the two that stood out to me were one, this valve would outlast me, and two, my blood would not need to be as thin as other valves would require, reducing the bleeding risks and allowing me to continue my adventures with very minimal change. This was all I needed to hear. The Onyx was for me. I still feel very fortunate that I never experienced severe symptoms of my failing valve. I did begin to tire easily, have very lightheaded, dizzy episodes, brain fog, and shortness of breath, all increasing rapidly as I neared my surgery date. But those didn't really start till after even my first visit with the doctor, the surgical team. The early symptoms chalked up to my thyroid and hormones were my heart all along, I now know. My surgery was on October 16th, 2018. My children and my dear friends were there to support. Of course, it went well. My wonderful surgeon had done thousands. He visited me when I was out of the ICU and let me know that my valve had been bicuspid all along, something I never knew I was born with. They had not been able to see it in the scans. It was not caused by the radiation treatment after all. I thought, wow, this is something that never even presented itself until I was 47 years old. I spent a total of 8 days in the hospital, twice as expected, due to my INR levels rising too high. They had to adjust and bring it down slowly to the proper level so I could go home. My recovery went well. Every day was better than the one before. I attended cardiotherapy classes, and I was told to slow down repeatedly. I had found an elliptical trainer with a hike simulation and video programs of trails in Europe. My first day hike was 9 weeks post-surgery. It was 13 miles, by the way, and I was exhausted. Once my 3-month recovery gate opened up, I was back snowshoeing, hiking, and training. My goal was to stand on top of Mount Adams again in July. Not once did I have an issue with my heart. And on July 7th, 2019, just shy of 9 months since my surgery, I stood on top of that mountain again. When I was practicing, I wasn't this emotional. Since my Mount Adams summit, I've added to my list of adventures 2 more summits of Adams, a handful of peaks in the Olympic Mountains of Washington State, and miles of backpacking and hiking. In 2022, I summited Mount Kilimanjaro in Africa at over 19,000 feet. And in 2024, we trekked through the Andes in Peru to Machu Picchu and Rainbow Mountain at elevations up to 17,000 feet. Never a problem. This summer will be the Tour de Mont Blanc in Europe, where I'll get to hike the trails that were on that elliptical trainer that helped heal me. And I guess just 3 things that I'd like to pinpoint that were as choosing Choose your hospitals, your research, or your surgeon, your cardiologist, and your care team. Advocate has been a theme. These are be long-term relationships, and they will empower you to have the choice. And also, I haven't heard it mentioned yet, but the term pump head is real. Emotional effects afterwards are real, and yoga helped me with that immensely. It helps heal the mind and the body. And in your recovery, just make every day a little bit better than the one before. That's it.
Thank you so much, Barbara, for sharing your story. I know it's not always easy. Next, we have another survivor story from Robin Peacock. A proud Californian, Robin Peacock will be sharing with us what it means to be a passionate patient advocate, helping others on the same journey as herself. From diagnosis and treatment from a bicuspid aortic valve and ascending aortic aneurysm, Robin has experienced what it means to navigate the health system and advocating for herself within her diagnosis. Along with being the Director of Patient Engagement for Heart Valve Voice US, Robin has been an active participant in clinical research, a Women Heart Champion, and an American Heart Association Circle of Red member. Importantly, Robin works within her own community, providing one-to-one support to those newly diagnosed with heart disease. Rock from the Heart is thrilled to have Robin Peacock share her message of positivity and proactive patient engagement in helping others. Please welcome Robin.
Hi. Barbara, oh my gosh, I just want to hug you. It's like, this is how I feel when I get into a room of other heart patients. You're not alone, and they get it. You know, you're an inspiration. You're a true inspiration, so thank you. So yes, I am Robin Peacock. I'm from Los Angeles, California, and I'm also an open heart surgery survivor. I was born with a bicuspid aortic valve, and I had the resulting ascending aortic aneurysm. Neither was discovered until I was age 43. They were missed. There's so many things about the conference already today. I've been taking notes. Every one of them I'm hitting, so I may be jumping around because our stories are so important. And so to go back to advocating for yourself, I have been misdiagnosed. My diagnosis has been missed, and I have had delay in diagnosis. So that's a whole arena in this heart world that I'm learning about. I also advocate for myself, and it saved me from sepsis. I had endocarditis, which is an infection which settled in my heart, on my heart valve, on my compromised heart valve, my bicuspid. It was a delay of over 6 to 8 months. No doctor could understand what was wrong because I did not present with a fever. And I had a subacute infection and a strep infection from my mouth. And so another piece, again, jumping all over, so I do apologize, but so many important things to share. When you have heart disease, your oral health is super important. And I go now for cleaning every 4 months. And it's just something I've put into the budget because it's that important to my heart, especially since I have had endocarditis. And endocarditis came in through my mouth. I had not had a recent teeth cleaning. They think it was just eating, chewing, flossing, something, a tortilla chip. Sometimes, you chip your roof of your mouth on the point of a tortilla chip. So the endocarditis settled in my legs, and it settled in as though I had just done 2,000 pliés and had shredded every muscle in my leg, and I couldn't walk. So here I was, a healthy 53-year-old doubles tennis player 5 days a week, hiker, paddleboarder, walk the dogs, all of those things. And all of a sudden I was in a wheelchair. And I didn't really have a primary doctor at the time because I kind of had fired my male doctor because he told me I was fat and he wasn't going to help me because I had gained weight. And so here's an 800 calorie a day diet and come see me in a little bit. So I really hadn't had a primary doctor other than my OB for a few years leading up to this endocarditis. I did have my cardiac team at Cedars-Sinai, my cardiologist. So he and I had been working together since 2007 when I received the diagnosis. So long story, endocarditis is a big part of my story. I am on a couple of different podcasts, one for Alliance for Aging Research. Last year I was their heart valve disease awareness podcast. So I do talk about it in online, and I'm happy to talk about it offline with any one of you. So advocating for myself absolutely saved my life because we ultimately did get a diagnosis. And I recovered after all of the medicine, the daily infusions, and here I am. A big part of my why is I was with my best friend when she was 42, and I was 39, and she dropped dead of a heart attack. And she was my doubles tennis partner, super healthy, 2 young boys. And at the time, age 39, I didn't know much about heart disease. And heart disease at the time for me was older men, smoker, heart attack, clogged artery, that kind of thing. I didn't know that women had heart disease. I didn't know there was an electrical portion of heart disease. I didn't know there was a plumbing portion of the heart disease. And at that time, I didn't know there was also an infectious portion of heart disease. So with Maureen passing, and then 4 years later, because I had gained this weight, I went and referred myself to a coronary calcium scan. This is going back to advocating for yourself, educating yourself. The coronary calcium scan came back with a 0, so I had 0 calcium in my arteries. But at the bottom of the report was a footnote, dilated aorta, 44 mm. This is from a major medical center in Los Angeles. Not one follow-up call. I just got a letter in the mail a couple weeks later. I didn't know what it meant because I just didn't think about it, so I Googled it, and it said aneurysm. It was Friday, April 13th, 2007, is when I learned I had an aneurysm because I sent myself, because I was heavy, to see if I was going to die like Maureen because I assumed she must have had a clogged artery because I didn't know there was electrical heart attacks at the time. So I ended up at Cedars. I had a friend up there, so I ended up there, and I was terrified because I felt like I was a walking time bomb. I didn't know if the aneurysm was growing, if it was brand new, if it was old. It was frightening. Long story short, it was a 4.4, so I had some window of time until surgery. That was that point that I discovered my bicuspid aortic valve. I'm adopted. I did not know my medical history. I do now. It's not on my mother's side. It is on my father's side. Ancestry.com found my father's family. I've connected with 21st cousins. I have 4 half-siblings, and there are 2 bicuspid aortic valves in that group of people. So spreading awareness. You never know by sharing your story. Here I'm jumping around again. Sharing your story saves lives. And sharing your story now helps others help others. We are in the time now, we're helping people that are going to be following behind us with the diagnoses. We are helping those that are currently diagnosed and need support. Barbara mentions mental health. So mental health is a huge piece of going through open heart surgery, of having any type of chronic condition or an emergency surgery. I'm meeting people who dissect and they're having these emergencies. I'm in shock. I had this nice little easy path, the watch and wait. And I'm meeting people here who've had serious emergencies. The mental health care piece is a piece that I'm out there advocating for clinicians and hospitals and integrative medicine, all of it, to watch the patients, give us the referrals to some type of therapy, some type of support, because it's real. I hit my depression about 5 months after my open heart surgery, and all of a sudden I became very snappy And I'm a Susie Mary Sunshine. I mean, everyone calls me Susie Mary Sunshine. I'm always upbeat, all faith, no fear, mindset is everything. And all of a sudden, I'm becoming this grouchy, grumpy person, and I realized I'm depressed. I need to figure out what happened to me physically, because there's a physical trauma to the body and there's a mental trauma to the body. And the physical trauma has to be processed. In my case, I had to process it. So I started watching the videos, the open heart surgery, exactly what happens to you. I had to know everyone who was in the room. It turns out this woman that I met through American Heart Association in Los Angeles, her father was my perfusionist. So her father literally held my life in his hands, besides Dr. Trento, the surgeon who had my heart in his hands. But it's an amazing world. And to me, as I stand here today, it is truly one of the greatest gifts of my life to have been diagnosed with a congenital heart defect, having an aneurysm, having endocarditis. Because what it's done is I am now so fulfilled at age 61 to be here, and to be talking on Capitol Hill. I was on Capitol Hill 2 weeks with Women Heart, which is another Women Heart, it's a volunteer heart patient organization. But to be sharing the story, to be fighting for the rights, for the equity in healthcare, to be fighting for, drugs to be paid for, to be fighting for women in research. I mean, the list goes on. I could talk a lot more than 10 minutes on this, but just know that I'm hoping that if and when you are diagnosed with heart disease, any other type of illness, serious or just minor, if you feel compelled and you want to feel fulfilled and help others, share your story. Every organization has a tab, I'm sure. Heart Valve Voice does. I know Aortic Hope does. I'm sure Rock from the Heart does. Everybody wants to hear your story because that's how we're going to make changes. Sharing your story is becoming such a buzzword. I was at a Global Heart Hub meeting, and we all talked about how sharing our story, getting the organizations to work together, how do we get the physicians, the clinicians to listen to us? I can go on a whole nother 30 minutes on how to advocate for yourself and questions and all of that. And you mentioned ask your doctor for a stethoscope, to listen to your heart. Well, as a female who was raised similar to Karen, where you have these hierarchies, right? The doctors, the lawyers, the policemen, those type, and those professions, and I'm a female and they're men. It's like, oh yes, okay, I can do that. Okay, sure. I'm not going to ask any questions because I don't want to be stupid. I don't want to be insulting them. And I will tell you, and I don't know how much time. I'm sure I'm over. I'm telling you that as I transition from patient into patient advocate, into the patient voice, into this director of patient engagement with Heart Valve Voice, my relationships with my doctors are changing. And right now I can tell you it's not so positive. And so, yes, in a perfect world, we should be able to be honest and talk about our fears and ask the questions. But I think there's this transition because I'm asking more questions. I'm questioning what they're telling me. I'm seeing them at conferences. I'm meeting their friends at conferences. I'm still trying to be super respectful. They are the professional. But I'm now a professional voice. And everybody in this room is a professional voice for something. So I'm always here to chat. It's Heart Valve Voice. I've got business cards. I do a lot of peer-to-peer talks. I talk to people. I visit people. I travel. I just want to connect. So please reach out, and thank you so much for this opportunity. And again, I apologize if I bounced all over like a ball, but there's so much to say, and I appreciate the opportunity. So thank you.
Well, I hope you all enjoyed your break. Next, we have Gretchen McCarrick from Johns Hopkins University. She'll be talking about aortic disease and genetic testing. What can it do for you? Gretchen McCarrick is an assistant professor in the McCusick-Nathans Department of Genetic Medicine at the Johns Hopkins University. She has more than 20 years experience working in aortopathy disease. Her cardiovascular connective tissue clinic is passionate about translating results of clinical and laboratory research back to patient care and coordinating multidisciplinary expert care in these conditions. She also supports topics for the aortic disease population through her involvement in an advisory capacity for the Marfan and Loeys-Dietz Syndrome Foundations. Thank you, Professor McCarrick, for sharing your expertise and passion for understanding the genetic underpinnings of aortic diseases. It is important knowledge for all patients. Please welcome Gretchen.
Thank you to everyone, especially to Amy and Pete. I will say that I do have a heart for this group and for Minnesota. I hope you'll forgive me that I transplanted to the East Coast, but I was born in Minnesota. I was a Golden Gopher. I'm from Duluth. So it's a pleasure to be back, but also my blood has thinned so much. It's so cold. I know, no. And thank you for the kind introduction. I have worked in the aortopathy space for about 20 years at Johns Hopkins, and so it's really a pleasure to be here. I'm only a little upset that I have to go after those incredible stories, and now you have to listen to some like nerdy scientific talk, but hopefully you'll learn some information. So pleasure to be here. So our agenda is to just talk some generally about genetic testing in the aortic disease space, to kind of go through some of the different syndromes and symptoms we think about that might prompt you a little bit more to head to a genetics clinic. And I wouldn't be a good genetic counselor if I didn't pull out some resources that are available for individuals. So big context, when we think about genetics, right, we're thinking about the instruction manuals that are telling our kidneys how to work, our heart how to function, our plumbing, our electrical systems in our heart. We have about 23,000 pairs of genes in the human body, but in perspective, we only really know about what 8,000 or 9,000 of them do in the human body. So only about 1/3 of our genetic information have we put together how that might impact what happens in our body. And then when we're thinking about aortic disease, we're down to about 38 to maybe 40 genes where we know if you have a mistake or a misspelling in that gene, it can impact how it works in the body. So we're really at the tip of the iceberg of learning the genetic etiologies behind aortic aneurysm disease. So who deserves genetic testing? The 2022 American Heart Association and American College of Cardiology came out with new guidelines that were actually very genetic friendly. So these guidelines are saying, actually, if you have an aneurysm and you're up to age 60, you should pursue genetic testing, especially in light of a family history, and especially in light of some of the syndromic features we're going to talk about. And actually, some of the European guidelines even go up to 70 years of age. So when we think about aneurysms, we can think about syndromes versus non-syndromes. Syndromics means there might be some external clues or features that might say there's a difference in your connective tissue. So your connective tissue is the glue that holds you together. And in some people, that glue is a little bit weaker, and that glue can be found in your vascular tissues, but it can also be found in your skin, in your joints, in your bones. So kind of this is a schematic of head to toe issues where if you find that there are birth defects like cleft palate, club foot, scoliosis, chest wall anomalies that the chest wall pokes in or pokes out, if you have people in your family who are really hypermobile, ocular problems like really aggressive nearsightedness, retinal detachments, and even the skin can give us clues. Some individuals with connective tissue disorders can have very significant easy bruising, abnormal scarring. All those are some kind of external cues that there might be a syndromic connective tissue aortopathy in the family. So then we think about genetic testing. What is that? So genetic testing, back in the day when I started 20 years ago, we were hardly ever doing it. It was really expensive to get. There was like one gene. insurance was a big hassle. And now, for the genetic testing, the amount of genes we can test on one panel has grown immensely. As well, the cost has gone down and the ease has gone down. So genetic testing these days, we can often do it via a buccal kit or saliva kit like you do for Ancestry&Me or 23andMe that gets sent to your house. And it gets tested for sequence or DNA changes in about these 40 genes or so. We're not looking for Alzheimer's or other cancer predispositions. We're really doing it for this dedicated reason. There can be different panels through different labs, but they are all under CLIA approval and very reputable labs. This is not, we get this question, this is not sequencing.com. So there are some Instagram posts where you can get your full genome sequenced for $400, and this is not that sequencing. If you really are interested in clinical genetic testing, you have to get it through a genetic counselor or a geneticist. You can't make these diagnoses on those at-home direct-to-consumer tests. And so when we're thinking about testing for aortopathies, we're pretty good at finding many of the genetic causes for those syndromic conditions. Not so great, we'll talk about bicuspid aortic valve and ascending aneurysm, which probably impacts a lot of people here. Not so great about finding those genes, it's kind of the holy grail. And for bicuspid aortic valve and ascending, it may indeed be that it's not one single gene change, one single gene that causes it. It might be a whole bunch of small gene changes that cause that, and we're just not at that point of technology to be able to detect that yet. Importantly, sometimes on these aneurysm panels, because we put a whole bunch of genes on them, there might be some genes that are actually not as applicable to you, where individuals might have to have very aggressive scoliosis at birth or intellectual disability. But because it's easier and cheaper to put them all together, it is all on one panel. And this comes into play because when we do this type of genetic testing, it's not like a CMP or a blood count where you get a specific number. We're doing DNA sequencing of the genes and trying to compare it to like what is quote unquote normal. And so when you're doing genetic testing and we're sequencing these genes for about 40 genes, you can get a negative test result, means that there was no variance found in the testing. Doesn't mean it's not genetic, just means as of 2025, in these 40 out of 23,000 genes that we tested for, there was no genetic answer. You can get a positive test, a pathogenic or likely pathogenic variant. So this is a gene change, it stops the gene from working. We're like 100% confident this is the predisposition to aneurysm. It helps us take care of you better. It gives us rules and tools which we'll talk about, excuse me. And also then it gives you information for family screening. So if we find a specific DNA reason why the aneurysm is occurring, we can go to siblings, parents, children, and test for that specific variant. And then sometimes on this testing, we get what's called a variant of uncertain significance. So this is a DNA change where we're not 100% sure it's the answer. We're not 100% sure we can blow it off as like a rare Asian, English, Scottish variant. And so in those cases, we do our homework, right? We say, how prevalent is it in the population? How many people are walking around with it? Does it track in the family? You know, if you have a sibling who also has an aneurysm, do they carry that same variant? So we do a lot of homework not to leave you in an ambiguous situation. Again, if testing is negative, however, it's really important to talk about family screening. In about 20% of cases of someone with an aneurysm, there is a positive family history of aneurysm in the family. And so if you don't have a genetic test to offer a family member, echo screening is really recommended for all first-degree relatives. This would look at the valve morphology, right, for that tricuspid versus bicuspid valve. It'd look at the aortic root diameters, and would look at the ascending aortic diameters. It's important to know in some of these conditions as well, like the bicuspid valve and ascending, if your child or sibling gets a normal echo and they don't have the bicuspid aortic valve, it's really important that they continue to get intermittent echo screening for the aortic dilation. That aortic dilation can develop over time, even independent of bicuspid aortic valve when you look at those families. And so one normal echo screen for that BAV should not rule out disease, and so those individuals definitely deserve echoes about every 3 to 5 years if normal. So the why. Why pursue genetic testing? One, it helps us test other family members, not only family members that are here, but especially for family members who are considering a pregnancy. They could test the pregnancy through a CVS or amnio when the woman is already pregnant, to be prepared to deliver at a different hospital if needed. But there's also technologies that allow you to do an IVF procedure and create embryos in a lab, and then try to pursue a pregnancy with the embryo that is negative for the aneurysm risk, to remove that risk from the family member. It helps us with surgical thresholds. So many of you have maybe heard of that 5 centimeter mark, where that is kind of the magic number where people think about having their aortic surgery. But there are some genetic predispositions that actually bring that surgical threshold down to 4 or 4.5 centimeters. So it helps us think about when is the right time to do surgery. It helps us think about imaging. What do we need to look at and how frequently? So some of these genetic conditions we'll talk about, the risk is really the thoracic aorta, but some of these conditions can put you at higher risk for brain aneurysms or aneurysms going to the kidneys or the legs. So if you have one of these genetic conditions, we're gonna MRA or CTAU head to pelvis every few years to keep you safe. It can help us with medical therapy. So I think there's a pharma talk a little bit later today, but there is some evidence that in some genetic predispositions, certain blood pressure medications may be a little bit better to use as a first-line defense. So many people get put on a beta blocker or an angiotensin receptor blocker, but due to the biochemistry of some of these genetic conditions, we might say, gosh, that angiotensin receptor blocker, it is helping the tissue from the inside, not just that hemodynamic blood pressure stress. So it helps us really strategize a better medication regimen for y'all. And then it can also help us with non-vascular guidance. So some individuals in some of these conditions might be at risk for orthopedic concerns or allergic concerns, and so it helps us kind of think of you as a whole person. So you've also heard earlier today about like precision medicine or personalized medicine, and actually the aortopathy space is a space where this has kind of come to fruition, where we know that there are guidelines, and guidelines are for the general person, right? But with the person sitting in front of us with aortic disease, we can really help tailor all of this care depending upon the family history. How many people in the family have had aneurysms? Has there been young sudden death? Has there been death due to dissections at smaller dimensions? We can make personalized recommendations based on the gene change that you have, not only the gene change, but the gene itself. We also take into account how fast is the aorta growing. Again, what is that absolute dimension? What does your genetics tell you about that surgical threshold? And then there's some really interesting science going into other what's called biomarkers or imaging markers that might put you in a more aggressive versus less aggressive category. So in our disorders, there's a lot of research into what's called vertebral tortuosity and or carotid tortuosity. These are the neck vessels that go up, and they should be pretty straight. But we know in some aggressive aneurysm conditions, they might be a little bit more windy. So we're getting to the extent of like how your blood vessels in your neck can help predict risk of dissection, which is pretty crazy when you think about it. So kind of the big, I guess 3 or 4 aneurysm syndromes that we think about. One, if you Google aortic aneurysm, you might have all come across Marfan syndrome. So this is a dominant condition, so it can get passed on, from a parent to a child. It is caused by gene variations in a gene called fibrilin-1. These are individuals who might be have a tall, thin body habitus, kind of shorter trunks, longer arms, fingers, legs. They can have an eye finding called ectopia lentis, or where the lenses kind of scoot around or sublux a little bit. They can have scoliosis, chest wall anomalies. These individuals are primarily at risk of aortic root aneurysm and tear. And so these are individuals with a disorder that is kind of a cousin to Marfan syndrome called Loeys-Dietz syndrome, or LDS. LDS was described and discovered at Johns Hopkins 20 years ago. We're celebrating the anniversary. And many individuals with Loeys-Dietz syndrome can have syndromic external features, but many people you might walk down the street and not even recognize. There's actually 7 genes for Loeys-Dietz syndrome. And there can be quite variable expressivity. So that means that you can see Loeys-Dietz syndrome in young kids who here present. You can see they have a little bit wide-spaced eyes, really translucent skin. You can see their veins, might have club foot, cleft palate. They can have cervical spine abnormalities, so really important to get this diagnosis so we protect their cervical spine. But then also you can have later adult onset, where individuals might not have those external features, but are still at risk for aneurysms throughout the body and early dissection. So really key to make this diagnosis. And this is a disorder where we bring down those surgical thresholds. There is a group of conditions called familial thoracic aortic aneurysm and dissection, or FTAD. And these are individuals who you can see in the family, clustering of aortic aneurysm and dissection primarily, maybe some cerebral vascular disease like strokes or early onset coronary artery disease. And these individuals tend not to have a lot of external features, but they have gene changes in these genes that are expressed in the vascular smooth muscle. So the way that your arteries and your aorta responds to blood pressure changes, that mechanism cannot work as effectively. The most common is caused by variations in the ACT2 gene. Here you can just see kind of a clue is that levator reticularis. So that's kind of honeycomb modeling. It has to do with your capillaries, and that vascular smooth muscle in your capillaries can be a clue. But these are individuals who might be at risk of stroke or cerebrovascular disease, so we want to pick them out too. And another very aggressive familial thoracic aneurysm disease is called PRKG1. And so this is a disorder where people can show aneurysms that rupture at normal diameters and at pretty young ages. And so if this was a diagnosis in a family, we would be very aggressive when individuals get into their 20s or so to really talk about very early surgical intervention. And again, both of these have impacts on your surgical thresholds. And then two more conditions. One is called vascular EDS. And so vascular EDS is a condition where you're likely not going to see aneurysm dissection, aneurysm thoracic dissection all in a family. You're going to see a cerebral hemorrhage and a sudden death and a splenic artery dissection and an aortic dissection. These individuals can have spontaneous arterial and aortic dissections. They can also have spontaneous hollow organ ruptures, so bowel ruptures. So this is very important to make a diagnosis of, so you can get very acute care in an emergency setting. And then clearly, people have touched upon bicuspid aortic valve and aortic aneurysm. Bicuspid aortic valve is quite common in the population, about 1% to 2%. It is a subset of that population that can go on to have aneurysm, typically ascending. So, right, the root is the first part of that candy cane of the aorta. The ascending is a little bit distal. But it's important to know that when you start echo screening family members, you can see bicuspid valve alone. You can see just aneurysm. You can see both. And in a small minority of cases, you can see some really severe left-sided heart defects, like hypoplastic left heart or congenital aortic coarctation, so where babies would be born and need surgery right away. So that's why it's important to make this diagnosis so people are getting fetal echoes if they're pregnant, etc. Again, the holy grail of genetics. It might not be one genetics, but we're not as great about knowing it. We know about 1 or 2 genes, maybe about 1% of BAV and aneurysm. And I just want to point out 2 resources that I think you have access to today. So I have some books out there. I got a grant from the John Ritter Foundation 2 years ago, and what was going to be a short brochure ended up being like an 80-page mental health resource. So if anyone would like some, oh, thank you. There we go, my Vanna White moment. I will have a whole bunch at the table. Please, please come and get them because they're heavy and I'm not bringing them back on the airport plane with me. And so I think I applaud everyone here, and it makes my heart really happy because I love patient stories. And I think as a genetic counselor, one of my jobs is to bring attention to mental health, PTSD, anxiety, depression, making sure people are getting into cardiac rehab, getting those mental health resources, getting that pain management they need, and sharing their stories with their families and others. So that's why I'm really, really honored to be here. So come check that out. And then you'll see the Aortic Hope resource, the aortic dissection, the patient guide, and this is really great. It's broken up into kind of 3 sections: living with aortic disease or dissection right afterwards, kind of the long term, and also for family members. And I think the Aortic Hope group has some of these books out there as well, and you can get them on their website. But 2 really great, just like patient empowerment tools that I would encourage you to use. So again, thank you so much. Sorry if I went a little bit over, but we'll be back for questions, and come meet me at the table afterwards. Thanks.
Thank you again, Gretchen. And before we move on to the next physician, I want to remind you all that if you have questions, please write them down on the index cards that are on your tables and hand them to Megan, and she's standing back there in the back. Next, we have Dr. Scott Pearson from Allina Health. He'll be talking about medication considerations for patients with aortic disease. Dr. Scott Pearson is a clinical pharmacist with Abbott Northwestern General Medicine Associates, where he practices at the Edina West location and provides comprehensive medication management for patients in a hospital-based internal medicine clinic. He completed his doctorate of pharmacy training at the University of Wisconsin-Madison School of Pharmacy, followed by 2 residencies at the University of Colorado. His practice, research, and teaching interests include cardiology, diabetes, geriatrics, and transitions of care. A huge thank you to Dr. Pearson for giving valuable insight into the whys of our medication and an understanding of that hidden layer of care at our doctor's office that supports our health. Please welcome Dr. Pearson.
Right. Thank you all so much. So from a pharmacist perspective, really my goal for this talk today is just to hopefully give all of you a little bit of a better understanding of a number of these medications that we commonly see in the management of aortic diseases. And so, let's see here. As far as kind of an overview, we'll kind of specifically touch on 2 particular populations. So we'll talk about people with more of this aortic aneurysm, as well as also kind of touching on more of the valvular component in people who have had an aortic valve replacement. And just for the sake of time, a lot of this will be a little bit kind of broader and a more general overview, but definitely happy to answer any more specific questions later on throughout the day as well. So to kind of dive in first, in terms of looking at aortic aneurysms, I think this is a lot of material that you guys are all familiar with and have heard in different pieces today already, but essentially when we talk about this aneurysm, it's kind of just a bulge in that aorta that, in many cases is related to plaque buildup over time. And the reason why we really care about this is because, as you've heard throughout the day, as these aneurysms grow, they can lead to a rupture or dissection, which is a medical emergency and something that really we want to kind of do anything that we can to try to prevent. And so when it comes to this management, as you've kind of heard as well, when these enlargements become much more significant, that's generally when we're looking at surgery. But in the earlier stages, when it's a little bit more of a minor enlargement, generally more what we're looking at is just kind of surveillance and watchful waiting and really trying to just prevent any further kind of expansion of that aneurysm. And so when we look at this, a number of pieces that we'll kind of touch on. So blood pressure control is going to be very important here, just when you think about the pressure of that blood that's pumping through the aorta. As long as we're kind of keeping that at a reasonable level, that's going to help to prevent some of that further expansion. And when it comes to blood pressure goals, generally, we're looking at least a goal of less than 130 over 80. In some cases, we might even be a little bit more aggressive than this if people can tolerate it, but that's something we'll talk a little bit more about. From another medication standpoint, statins are something that we'll also talk more about, in particular when there is kind of a plaque contribution to these aortic aneurysms, something that can help to reduce some of that plaque formation. And then a couple of things we want to try to avoid. So tobacco is certainly a risk factor in itself of just having this aneurysm develop, certainly not the only risk factor, but one that if people are using tobacco, we really want to do anything we can to try to get them to quit. And certainly from a pharmacy standpoint, we have medications that can help with that we won't get into now, but certainly that's a big risk factor management piece. And then the last one here, I think this is an important one that, again, when we think about some of these advocacy points that have been made earlier, I think is a really important one for you all to be aware of. So there is a medication class called fluoroquinolones. They're a type of antibiotic It would include things like ciprofloxacin, levofloxacin. And these antibiotics in people who have an aortic aneurysm, there's actually some evidence that they may somewhat increase the risk of having a rupture. And so, it's not an absolute that we can never use these in someone with an aneurysm, but definitely something we want to be thinking twice about. And so, especially if you're getting care in, say, an urgent care where they maybe don't know your whole history, just kind of important to have this in the back of your brain and make sure that they're aware of this as they're making decisions. All right, but to dive a little bit deeper into blood pressure management. So as noted by our previous speaker, beta blockers generally are going to be one of our first go-to options when it comes to blood pressure. So get into kind of the alphabet soup of medications here. These are kind of our OLOL ending medications, so metoprolol, carvedilol, atenolol, if you guys are familiar with any of those. So the reason why we really like these in the aortic aneurysm setting is that in addition to lowering blood pressure, they're also going to be working to decrease the heart rate. And also, by doing that, they also reduce some of the pumping function of the heart and some of that contraction of the heart. And by doing all these things, really what they're doing is, again, kind of working to take some of that pressure off of the aorta as blood is pumping through. So in general, that's going to be one of our first go-to options. Beyond that, I'll say, again, when we're looking at blood pressure goals, really any of these kind of other blood pressure lowering medications can be great options. Love, as our previous speaker mentioned, I think an exciting area thinking about specific nuanced situations where we might prefer one medication as opposed to another, which we could probably have a whole nother talk about. But big picture, we're worried about that blood pressure number in itself, and generally, other medications that are lowering blood pressure, all great options. And so a few things just when it comes to monitoring of blood pressure that I think are important just to kind of be familiar with. So, with any blood pressure lowering medication, certainly possible that this can lead to some lightheadedness or dizziness. And especially with changes in position, this is something we can commonly see, or if we happen to be lowering blood pressure too much, these are things that people can experience. So especially with any of those changes in position, trying to avoid jumping right out of bed, kind of just, again, kind of taking time with any of those changes. In addition to that, when we talk about beta blockers, something a little bit more specific to those medications is that especially when people first start these medications, fatigue is fairly common. And for anyone in the room who has started one of these medications, you may have experienced this. So I bring this up because it is something that typically will improve over time, just as our bodies kind of accommodate and adjust to having this lower heart rate. Typically, as long as it's something that is manageable, over time it is something that will become just kind of more common and less of a concern typically. And the last thing I bring up here, so home blood pressure monitoring, especially as we're working to get blood pressure under control. This can be a great piece as well. As you all know, when you drive in through the ice and snow and come into the doctor's office, very common that your blood pressure is going to be a little higher. So nice to have some of these readings at home as well, just to give us an idea of how you're looking in the big picture view and not just looking at that 1 or 2 points in time that may be different. All right, and kind of last slide I wanted to touch on here related to statins. So these are medications that lower cholesterol levels, but what they're also doing, and kind of more specifically what they're doing, is they are reducing some of that plaque formation that can occur within the arteries and within the aorta. And what they also do is they work to kind of stabilize some of those plaques that are already there. And why this is important is when those plaques break off, that's what can eventually end up leading to either a heart attack or a stroke. And so, when we look at people who are at higher risk of things like heart attacks and strokes, that's why these statin medications are so widely recommended and why they have so many benefits just at helping to reduce things like heart attacks and strokes. And so with that, again, because in many cases plaque formation can contribute to these aneurysms, that's why there is some also thought that these statins may help to kind of slow some of this aneurysm growth. So in many cases, these are things that will also be recommended as part of that surveillance. I did want to touch on side effects as it comes to statins as well. So again, this is medication that many, many people are on, and I feel as though, when you have lots of people on medications, you sometimes hear about the bad things, and in certain circles, for whatever reason, statins have gotten kind of a bad rap. And I bring this up because I think it is important to know that there are side effects that can occur, and I'd say the most common thing that I kind of counsel people about is just to watch for muscle aches with statins. So probably about 1 out of every 10 people may experience these. And in general, it tends to be more of an unexplained kind of soreness in the larger muscles like the legs. So this is an important thing to be watching for. And if you experience it, definitely letting your care team know. Typically what we would do is kind of take a trial off, see if it improves. And in many cases, if it is a case where someone could benefit significantly from being on one of these medications, oftentimes we'll try a lower dose of the same statin or even a different statin, and in many cases, people are then able to tolerate them. So, if you worked out yesterday and you're sore, probably not your statin. Again, kind of putting this into context of more of the unexplained types of soreness, but definitely things that we do want to be watching for. All right, so as far as aortic aneurysm medications, that's what I'll kind of leave things at there. And in general, these are medications that many people are taking for other reasons already, even when this aneurysm is discovered, but definitely going to be important pieces that can help to reduce some of that risk. But what we'll kind of dive into for the remainder of the talk here is looking more, again, at valvular disease. And so when we look at the aortic valve, as we've heard from some previous speakers, there can be a number of issues with this valve. There can be issues with opening of the valve, with closing of the valve, or with certain types of congenital heart valve defects. And in any of these cases, when things become more severe and it's leading to symptoms, typically the management is going to be looking at replacing that valve. And again, from a big picture view, the two main types of valves that we're looking at are going to be either mechanical or bioprosthetic or tissue valves. And as we'll talk about, as it relates to medications, the type of valve that someone has is going to dictate a little bit of what we recommend. And so the reason why we start thinking about medications in this valve replacement population is because when we have a valve replacement, there is a possibility for a clot to form on that valve. And if that happens, if that clot essentially gets pumped out and goes up to the brain, that's what could cause a stroke. And so with that, with any of these valve replacements in the aorta, generally we're going to be recommending some form of a blood thinning medication just to help reduce that risk of stroke. And as long as these medications are being kind of taken and prescribed as recommended based on the valve, the risk of this stroke occurring following a valve replacement tends to be very, very low. But as we talk about these medications, really kind of two main families that we'll touch on. So first we have antiplatelets. This would include just your over-the-counter baby aspirin, as well as some other prescription medications, clopidogrel, ticagrelor, or prasugrel. And then we also have anticoagulants. So with anticoagulants, these are a little bit of kind of stronger blood thinning medications. If you guys have heard the term DOACs, this is some of our newer agents like apixaban, rivaroxaban, and then also warfarin, which has been around for quite some time, and what we'll kind of spend a little bit more time talking about because it is a little bit of a more nuanced medication. But when we look at the type of valve replacement, again, our recommendations are going to be a little bit different depending on what type of valve it is. So with these mechanical valves, one just kind of general piece with them is that they do tend to have a longer lifespan than the tissue valves. But the flip side of that is that they do tend to be also kind of a higher clotting risk. And so for anyone who's having one of these mechanical aortic valve replacements, generally this is going to be something that requires lifelong anticoagulation with warfarin. And I bring up here too, so the DOACs, these kind of newer anticoagulants, are not going to be recommended in this population. We have evidence that's shown that there's basically are worse outcomes with people being on these DOACs. So for mechanical valves, really warfarin is going to be our go-to option here. Now with the bioprosthetic or tissue valves, because these are kind of lower clotting risk in general, for most cases, just being on an antiplatelet like low-dose aspirin is going to be sufficient for this stroke prevention. There are some circumstances where warfarin or another anticoagulant may be recommended, with either initially right after the valve replacement over the first several months, or if there are more complications related to different types of thickening with the valve. At this point, warfarin is, of those kind of stronger anticoagulant medications, is really the one that has kind of demonstrated the most evidence. But this is an area with the tissue valves that we do have some ongoing studies looking at the DOACs in cases where something else may be needed. So more to come in that area, but again, in most cases, we are looking at warfarin when it comes to one of these anticoagulants following a valve replacement. All right, so when we talk about blood thinning medications, as you might expect, most common side effect and thing that we're kind of watching for are certain signs of bleeding. And so, things like bruising more easily, getting a cut, taking a little bit longer for that bleeding to stop, those are things that are very much to be expected and really the most kind of common sources of bleeding that we tend to see with these blood thinning medications. But the things that we do watch a little bit more closely for and monitor for are more of these kind of signs of bleeding in places where there shouldn't be. So blood in the urine, black tarry stools, head injuries, all things that would be more cause for concern. And with head injuries, that's kind of an automatic ticket to the emergency department if someone is on medication like warfarin or an anticoagulant, just to be safe and make sure that there's no bleeding occurring in the brain. And so with that, certainly with being on these blood thinning medications, we do try to encourage being a little bit more careful with activities. If you see professional athletes when they're on blood thinners, generally they're out for the season, and that's because we want to limit any sort of kind of unnecessary or kind of contact that could lead to more of these injuries. But to kind of close here, the last piece I wanted to just talk more about is this medication warfarin. As you saw, I mentioned this a number of times as we look at kind of the post-valve replacement regimens. And warfarin in itself is just kind of a unique medication because its effects are impacted by a lot of different things. And so if all of us in this room were taking warfarin, we would all need to take probably a slightly different dose in order to get that desired level of blood thinning, just because it is so unique in being affected by so many things. And so with that, there is actually a lab value that we check called the INR that is kind of specific for people on warfarin to look at that level of blood thinness. And when first starting warfarin, this is a lab that we do need to check fairly regularly, even a few times a week. But once we start to kind of figure things out and we see what that kind of proper dosing is going to be, over the longer term, and when people are stable on this medication, it tends to be something that we're okay with checking every month or so. But to speak a little bit more about some of the things that can impact warfarin, so diet is a huge piece here. So warfarin acts against something called vitamin K, which is part of kind of our body's clotting mechanism. And by doing this, basically vitamin K is something that is basically present in a lot of the foods that we eat. In particular, when you look at things like the picture here, a lot of our green leafy vegetables, so spinach, broccoli, kale, things like that. A lot of times I think people get the idea that with being on warfarin that you can't eat those things. And although you can use that as an excuse if you want, that's not necessarily the case. It's more that we want to be consistent with these types of foods that people are eating. And from week to week, if people can stay relatively consistent with them, then we're able to kind of adjust the warfarin dose to accommodate for that. Another big thing that can impact warfarin is other medications. So when we look at medications, there are some medications that also have blood thinning properties of their own. A big example of those are what are called NSAIDs. So this would include over-the-counter medications like ibuprofen, naproxen. And so in general, when someone is on one of these anticoagulants like warfarin, these are things that we generally will recommend avoiding just to try and minimize any further risk of bleeding with that combination. Supplements also a type of medication that often have blood thinning properties to them. And so this is something oftentimes we're looking at kind of risk versus benefits, but looking if there is a potential additive bleeding risk, oftentimes things that we'll be trying to maybe steer away from. Now, there are also medications that can either increase or decrease levels of warfarin. Big example here is antibiotics. So even with a short course, a lot of antibiotics can have fairly significant effects on warfarin levels. And so this is something that kind of take away with all of these points is that, for anyone on warfarin, it's just important that with any changes in medications, so stopping, starting anything new, whether it's prescription, over-the-counter, supplements, or substances, as I note on here, things like cannabis, tobacco, alcohol. These are all things that can impact warfarin, so just important to be communicating any of these changes with the warfarin clinic so that they can be adjusting and probably checking this INR lab more frequently to kind of accommodate for that and make sure that we're able to manage it safely. All right, so to close here, I think it's my last slide, but to talk a little bit more about supplements that I had kind of mentioned on the previous slide. So this is something that I think in all kind of sectors of healthcare, we've been seeing just a boom in kind of usage of over recent years. And you know, when we think about supplements, one of the challenges that we have is that unfortunately we don't have the level of regulation for supplements as we do for, you know, our prescription or over-the-counter medications. And so, you know, there have been cases where there are certain contaminants and unknown things being in these supplements that aren't actually listed on the bottle. And, you know, with that, especially with warfarin being impacted by so many different things, this certainly could be a cause for concern. And so, you know, one takeaway from this is that I tend to be more of a minimalist here, that if there's not a great reason and a clear benefit of taking a supplement, generally, especially with being on a medication like warfarin, something I might steer more away from. But if there are supplements that people are taking, something that I definitely do recommend for anyone taking supplements just in general is trying to look for one of these organizations' kind of seals that are listed on the slide here on the bottle. So basically, these are organizations that look at what's on the label and what's actually in each pill, and they just kind of ensure that it is what it says it is and that there aren't additional things included as well. So this is just another way of kind of having some of this regulation in place. And the USP that's listed on the top, I'd say is probably the one that's, you know, most commonly seen, but just another kind of good advocacy type thing to be aware of with that. And the last thing on here, so vitamin K is something that also is in a lot of supplements, things like multivitamins. It's also in certain protein drinks. And so just being aware of that as another source in addition to some of the dietary vitamin K, just to be aware of as well. All right, so I know that was kind of a whirlwind, but to recap, so aortic aneurysm management, generally when we think from a medication standpoint, we're looking at blood pressure control and potentially looking at statin medications as well, kind of addressing that plaque component. In terms of aortic valve replacements, these are kind of scenarios where we are going to be looking at some sort of a blood thinning medication in terms of long-term management. And then warfarin is sort of this nuanced medication that is going to have a little bit more kind of going along with it. And you know, certainly as far as factors, I know this can be a little bit overwhelming, kind of hearing for the first time. But you know, I'll say too that with that, it is something that as people are kind of familiar with this information and, you know, able to kind of adopt, you know, things in their lifestyle that are kind of conducive to this, you know, as long as we're able to keep this lab value within our target range, it is a medication that can be used very effectively and safely. So hopefully this was helpful just to give you a little bit more of an overview of these medications. I'll also be around for the Q&A session later and love to answer any questions that people have, so thank you.
Thank you, Dr. Pearson. Next, we have Katie Crystal from Allina Health, Minneapolis Heart Institute, and she will be discussing navigating aortic emergencies, the patient journey. Katie Crystal is a registered nurse clinician who has worked with cardiac patients and families at Allina Health since 2008. Several of those years were in the cardiac intensive care unit, caring for patients following complex surgery, including those with valve and aortic disease. She joined Minneapolis Heart Institute in the cardiovascular emergency group 3 years ago and has enjoyed working closely with their aortic program. Katie provides education and outreach to emergency departments, EMS, and transport crews in the upper Midwest to successfully care for medical emergencies and support families during critical events. Katie enjoys sailing and spending time in the Great North Woods. We are so pleased to have Katie share a depth of knowledge on what can be a stressful and scary situation for patients and their families. Thank you for serving our community. Welcome, Katie.
Well, hello. Thank you so much for that welcome. And I'm so thankful to be here today. This is my first Rock from the Heart event, and I know it won't be my last. So it has been a pleasure meeting everyone, and look forward to speaking with you today. So we'll start with just that idea of what does it look like when someone experiences an aortic emergency and during that scary time. First, we'll take a look at the acute aortic syndromes that often present and then subsequently lead to an emergency room visit. So the slide shows the three main types of these conditions. First, we'll start with on the right-hand side. So penetrating aortic, atherosclerotic ulcer is essentially plaque that has formed that will start to go through the wall of the aorta. This can be quite progressive, and in fact, it can progress to an aortic dissection, ultimately going through all the layers of the wall of the aorta. Intramural hematoma is essentially just a hematoma or collection of blood that forms in between the layers of the aorta. There is a lot to say about the exact cause of these. Sometimes it's said to be the vessels that surround the wall of the aorta. That can sometimes burst, lead to rupture as well. And then aortic dissection, which many of us probably know all too well. And certainly this is the most common of the aortic conditions, and certainly a very emergent at that. So when we look to other things as well, if we have aortic trauma, that can certainly bring us to the emergency room, and then ruptured aneurysms as well. So we'll kind of touch on some of these as we look at that path. We know that aortic dissection is by far the most common, accounting for 85, some literature says up to 90% of these diseases. So when we look at symptoms, we know that the main symptom is going to be this sudden severe chest pain that many of you may have heard described. It can be sharp, ripping, tearing, something sudden that you know that something is not right. It also can be neck and back pain depending on the location of wherever this is being affected in the aorta. And certainly it can go all the way down to the abdominal aorta, so it can lead to some stomach pain. Additionally, then, you can also have symptoms of stroke, heart attack, severely low blood pressure that can eventually lead to an unconscious situation too. And we'll talk a little bit more about that here on the next slide and the reason for some of that. So I like this slide just to show how incredible the aorta and all that it does, right? So it's the largest artery in the body. It supplies many of our major vessels, and certainly supplies blood to our major organs as well. So it's a truly amazing network, but when you see its extensive nature here, you can really start to understand how if something is wrong with a part of your aorta, how many other things can be affected. So for example, if you have a dissection that involves the vessels that supply your head, you can start to show signs of stroke. So any of those symptoms that we're commonly used to, so changes in speech, vision, weakness, etc. If you have a reduction in blood flow to some of the vessels that feed the heart, then you can start showing signs of a heart attack, and you can in fact have a heart attack along with an aortic dissection or another aortic disease. If it progresses further into the subclavian arteries, then you can start to have issue with limb weakness, paleness in your limbs, and other things that can affect that circulation piece. And then as it continues further down, you can have, back pain, stomach pain, etc. Any one of these is a reason to come into the emergency room, right? And even though we know that, I think getting there can be half the battle, right? We have societal norms. Nurses are by far, ER nurses, I think, are one of the toughest group to get to the emergency room. So I can speak that I know that I'm really saying it for myself too. It is important, but I think there's a lot of reasons that we can wait to seek care, right? We start to doubt ourselves. Is this really an emergency? What is the ER like today? Is it busy? Cost concerns? Will it get better if I just wait a little longer at home? I think we've all talked through some of those things. I like to share just one story with this that has really stuck with me. I've worked in the cities here, but I now live 4 hours north of here, and so I was working at a regional hospital up by my area. And there was a call from a daughter who said, I'm coming in with my dad. He's had severe, sudden pain that started this morning at 8 a.m. It was now almost 6 p.m. By the time he came in, Unfortunately, he was almost unconscious. It was a pretty dire situation. And when we asked the reason he waited, it was just because he hadn't seen his daughter and they were fishing for the day. And it's reasonable, but it has stuck with me for years. Because unfortunately, we never know if the path would have looked different. But certainly we had a good 8, 9 hours, where he was experiencing this pain that he described as something he had never felt before. So I think, you're worth it, and I think all your loved ones would agree as well, that coming in when you feel these, regardless of some of those norms that are so ingrained in us, is so important. And we know this, that any one of these symptoms, once we get there, are so time sensitive that we know outcomes improve when we can get, started with the process much sooner. And I know that's something that you probably have heard or have been told, but it is, proven in the literature that time is really important here. So I think the other piece is that once you get there, then we really start a quick process. So you've made it there, and now we need to get to a few things quickly. Any of one of these things would be a reason to call an ambulance. But again, that's a whole nother step, right? Getting there on your own, but then calling an ambulance. And we have a whole set of things that can talk us through that too. Once you enter into the emergency room, for those of you who have not made a visit, that triage process, if you come in with something like, very stabbing, sudden chest pain, that will get you to a room very quickly. And it will probably have, a lot of momentum to that. But certainly if you come in via EMS, that's one of the many reasons why there's certain things that really benefit from that. You get into a room and you get to be seen by a provider right away, and that really starts that time clock. You've made that choice to come in with this symptom, and that's very important. We know that for every, 1 hour that goes past, there's that 1% decline in chance of survival. So it is very important, and I can't reiterate that enough. Once you're there, we really need to start getting to the why, and that's when things can start to feel very busy, right? So we need to make sure that you see a provider quickly, get that physical exam. We know that, chest pain is the most common symptoms with some of these aortic disease. However, it accounts for only about 2% of the chest pain that presents to the emergency department. So a lot of what happens next is we want to try to find out why you're having these symptoms, but also at the same time, what can we rule out, right? And so tests will happen pretty quickly. We have a lot of protocols in place, certainly, for this, and that just really helps us as caretakers get things done in a very systematic and efficient way. So we know that the time of presentation to treatment, again, can mean the difference between life and death. So at this time, you have a room full of ER staff, and they're really starting to look through everything. The provider will start a physical exam. There is certain things with chest pain once they get an EKG, and that can certainly be definitive for many things, including heart attack. Then we start to look at, for aortic disease, we can look at high-risk features, pain features, right? So that's stabbing, sharp pain, any previous risk factors you have, and then anything on exam that may have sparked some concern. And really the idea is, can we put this puzzle together more quickly? So again, we can just really get to that definitive diagnosis. So certainly an EKG, IVs, possibly medications. Many patients that come in with this may have some high blood pressure initially. So as we're getting some of those things started, that certainly will be important. And then imaging. This is really our gold standard to, deciding what you have going on with the aorta and for many other things, but it has a high sensitivity to aortic disease. So certainly that will be in the piece. CT is really good because it's fast. It's usually available 24/7, even in small regional hospitals, so it's something that's readily available to us, and that is also very important. So once all this is happening, this is, very intense, as I know I've been part of these situations where there's a lot of nurses, providers, other staff in the room, and there's, so much happening. If you are a loved one in that room, it's okay to step out, it's okay to call, a friend, a family member, know that your loved one's being taken care of, but this can be a real stressful time. And I wish we could say that we could calm that room down as much as we could, but really just know that we're aware that a lot is going on, but it's really just for that timepiece, although it can be difficult. So if blood pressure is elevated, we certainly want to try to reduce that. That will reduce stress on the wall of the aorta. So managing heart rate and blood pressure is a huge piece of that. The other is if your blood pressure is too low and we're in kind of a dire situation, certainly then we'd start quick treatment for that as well. So it's really that time we need to get to that diagnosis and really rule out other things. There's, as I mentioned, there's protocols, and I think, we have protocols in place for some of these emergencies, just as we would for cardiac arrest protocols, and that's because it really can get us in a state of excitement. Also, we want to make sure we're not missing anything. We want to make sure we're being very efficient. So those are always being looked at as something as a gold standard to say, we want to make sure that we can accommodate this patient as much as we can. So if you, in fact, get a confirmed diagnosis of an aortic emergency, this is really when a lot of things start to go into place. So first, treatment. And this is really going to depend on the area of the aorta that's affected. So for example, in the arch or the ascending aorta, this is really a surgical emergency. And there's going to be a consultation and some discussion that will include both cardiac surgery and vascular surgery very quickly. If you have an uncomplicated or a stable dissection lower in the aorta, this is something that can possibly be initially managed medically, so blood pressure control, etc. However, that changes to be more of a complicated case if we start to have any signs of limb malperfusion. So for example, things that I was talking about like the coolness, the paleness, the loss of sensation, etc., or any of the vital organs are affected from that lower abdomen, that would something then vascular surgery wouldn't get involved very quickly. The other big piece of this that can occur between 60 to 70% of cases is someone is presented to a center where they do not have surgical capabilities. We know that transfer to a high volume aortic center does make a pretty vast difference in outcomes for patients. And so a big conversation is now you've had this diagnosis, and now we're telling you we need to get you out of your hometown and we're transferring you someplace else. And oftentimes it can happen so quickly, and it's with very little warning. Just know that we recognize this in the community as this is something very difficult, but the process, if you can understand it, is super important, and that is understood, but there's a lot of things that goes into that, and there's a lot of stress that is now entering your world in a pretty fast manner. So if we can work with that center to get you accepted and start the process of looking at things, we do that as quickly as possible. Again, understanding that that can be a pretty difficult piece. Once you're accepted, so either you're transferring to a center or if you're at an aortic capable center, there's a lot that goes into multidisciplinary communication at that time. So cardiology members, cardiac surgery, vascular surgery are all connected usually via a one-call system. And so then we are all linked together where we can look at images real time, we can start to look at surgical options and treatments. And that can all happen as you're either being transferred or being prepared for surgery. So this is really a huge, important piece to how everyone gets connected in a fast manner. Again, all with the idea that we know it needs to happen pretty, expedited. This is also a time where if you are a loved one, I encourage you to find a family member or a friend that might be able to make some of those difficult phone calls or keep in touch with a lot of the information as things will be happening so quickly. You need to focus not only on yourself and making sure you're okay, but this might be part of the time where you're now going to be traveling to a new city as well, and that comes with a whole different set of challenges. If you do need to be transported, there's a couple ways, and this might be review for many of you, and it might be close to some of you. And so, there's a capability of going via air, and that can go by helicopter or by plane. Certainly, these are for some of the longer distance transfers. We need to also think, though, that even something 3 hours away can sometimes be achieved quicker via ground, because we need to get an ambulance from the hospital to the airport, from the airport to the other facility, again to the airport, and then have a ground crew take you back. So we certainly look at timing, and we talk with our crews very closely about proximity and how we can most safely get the patient there, and then what is really available. Of course, things in this time of year, weather certainly plays a big factor into this as well. So sometimes transport can be quite problematic. I know, for example, up where I am from, or where I'm living now, we have one crew oftentimes at night, and we have one crew during the day with another that's available for transfer. So oftentimes we're relying on our crews around, and again, this all happens very, very quickly in order to make that possible. If you are having a type A aortic dissection or another aortic disease and surgery is available to you, and now you've made it to that center, or perhaps you were at an aortic center, the surgical teams have been working hard to not only look over those images, but to prepare for the type of case that they're going to do for you. Also, a big piece, and I have a study to kind of look at why over the last couple of years we've looked at this more closely. But we need to arrange to meet the patient either in the emergency room, or sometimes we go directly into the operating room. Sometimes that emergency room stop is simply to sign a consent or meet your surgeon, have an idea of what the next steps kind of will look like for you. Certainly, we've learned over the literature, and again, the study I will look at shortly will just show that we know that there is a significant decrease in time if we can go directly from the operating room, either once a patient arrives or if they are in the emergency room. And that's this here. So this was a study in the American Journal of Emergency Medicine. This was from 2020 in the area around Chicago. And it was showing that adult patients with type A aortic dissection, they looked at 42 patients before they implemented what they were calling direct to operating room kind of program or algorithm, and then there was 84 that participated after this program was in place. And essentially it was, kind of what I spoke about, 24 hours, 365 of cardiology, vascular surgery and cardiac surgery collaboration in order to try to get someone directly to the operating room from an emergency room. And they looked at many that this was being transferred to that center. So what they found was that median time from acceptance of transfer from the emergency room physician to the operating room arrival time was 82 minutes faster in the direct to operating room group compared to the pre-program group, and that was pretty significant. Median time from the arrival to the operating room was 72 minutes faster, again, in that direct to operating room group, and in-hospital mortality went from 16% to 12% in that 84 that did that study. I know, essentially we looked at this was good, right? We know that this was worth some time and it was worth looking into. Since then, I know that we have done some of that, and I think this has been kind of standardized to make it the least amount of stops and complications. I think the only way to avoid that is if they're coming from a center that may not have the imaging capabilities that they need in order to really get to that diagnosis, so they can have the tests ordered, get to the emergency room, and potentially just have a study done on the way to the operating room. But there is very few reasons to make an official stop in the ER, and now it's really just kind of a breeze through. And we know that that is really helping us with some of those times, and really any time we can decrease that time from diagnosis to surgery, we know we have a better chance and outcomes there. I can tell you that process improvement for aortic dissection and education is ongoing. I help a lot with protocols. This is one example of a checklist that's out there, and really it's just saying, again, we want to make sure these things are systematic, so as we know this heightened situation is happening, we're not going to forget anything, and we know the communication can stay consistent. We also don't want extra phone calls, and so that's why a lot of our join together has been multiple people on the call at one time. So this is just one example. We also have several for our group that we use, but we're always looking to make that process more streamlined, certainly. And I'll just finish up with a few ways that my group does that, and that is with the use of simulation. And we go out to the emergency departments, and I can tell you that when we get requests for what type of emergency you'd be interested in, I would say it's almost always aortic dissection, right? We get a lot of experience with heart attacks, and we even get quite a few, we get stroke and heart attack. People feel pretty comfortable with that. Aortic dissection, not so much. And so we get as much of a request for that as we do with some of our larger resuscitations, and it's for the same reason. We don't see it very often, which is great, but people want to be proficient in this, and so we want to assist them with that. So this is one of the simulators that we have. His name is Hal. It's pretty incredible. He can talk, he can breathe, we can give him medications, and we can monitor what happens afterwards. We can put him on a ventilator. What else? He's pretty high fidelity in the sense of we can get a realistic sense. And so we'll bring Hal out, and then we actually have the other simulator in the room, and yes, we really do sometimes put him in the car this way if we have a van full of things, but we essentially bring an ultrasound simulator out, and then the provider or the advanced practice provider in the emergency room is able to ultrasound the patient and look at different pathologies. He is able to say, okay, we have a positive aortic dissection or other, and then the nurses are able to run a full simulation. And so we can go side to side and really learn from one another. And we found this to be pretty helpful for some of our emergency room groups. The other pictures there, one is in the emergency room too, and again, we started out with a patient who had some crushing chest pain, and we had EMS involved with this too, and so we were able to pull in someone that had called 911, bringing them into the emergency room, and practiced it from start to finish. And this is just one way that we can learn to be as proficient as possible, and really to ease some of that nervousness that can come with something that we don't see very often, and we know how important it is to do so. And then just the ultrasound mannequin in action. It has augmented reality, so that's sometimes fun. We can see things, we can practice, and it's just an extra thing to make it that extra special. But I will end with that today, and look forward to any questions you may have. And thank you so much for your time.
Thank you, Katie. Next, I would like to welcome Dr. Edwin Zishiri from Allina Health Minneapolis Heart Institute. Dr. Zishiri will be discussing aortic root and arrhythmias, a brief update on the cardiac conduction system in health and disease. Dr. Zishiri, a cardiac electrophysiologist at the Minneapolis Heart Institute. After receiving his medical degree from the University of Zimbabwe in Harare, Dr. Zishiri completed his cardiac electrophysiology training as Chief Fellow and Cardiology Fellowship at the Cleveland Clinic, and completed his training at Boston University as Chief Medical Resident. He went on to hold a number of physician leader roles during his time at Michigan Heart in Ypsilanti. Dr. Zishiri clinical interests include complex and catheter-based arrhythmia ablation, pacemaker implantation, and prevention of sudden cardiac death in patients. We are grateful to have Dr. Zishiri share his clinical expertise on such a complex subject, and thank you for being a part of the Minnesota community. Welcome.
Perfect. Thank you for having me over here, and yeah,
It's not common that I get asked to speak at an aortic center, being an electrician, a heart rhythm cardiologist, but it's been quite interesting to listen to the previous speakers who have spoken very eloquently, and I'd like to point out, the patient survivors. I found their stories very edifying, and hopefully I'll become a better provider as I talk about this. So when I got asked to speak about at this session a few months ago, I thought, gee, what can I say about aortic disease and arrhythmias? And over time, I decided that maybe I could share some stories and that will highlight the conduction system of the heart and how it's related to the aortic root, and show you some of the things we're passionate about in the field of electrophysiology. So I have no conflicts of interest to disclose for this talk or others. As I was coming up with the goals, I decided to review the anatomy of the cardiac conduction system and introduce some of the tools that we utilize in the EP lab, both to understand any cardiac rhythm abnormalities, to locate where they're coming from, eliminate tachyarrhythmias, as well as treat bradyarrhythmias. I will mostly do a show and tell type of presentation, and I'll show some EKGs and some images and briefly review some of the things that we do in the EP lab, and hopefully as I do that, I'll save a few minutes. The Q&A session, I think, is going to be at the end after all the speakers have spoken, and I hope to not bore you to death as I do that. Okay, so this picture shows the conduction system of the heart. So, do I have a pointer here? Yes, no, there's no pointer. Oh, well. I basically live and breathe, the anatomic relations of this picture as we see. So at the top of the screen, on the yellow mark, is where we typically have the compact AV node, which is the structure that connects electrically the top chambers of the heart to the bottom chambers of the heart. And it typically sits at the apex of the triangle, which is called the triangle Coke, where on the picture it is written His bundle region over there, and it is bound posteriorly by the structure called the tendon of Todaro, anteriorly by the septal leaflet of the tricuspid valve, and inferiorly by the coronary sinus ostium. I always think about this picture and look back at, when I was newer in the field of electrophysiology, and a lot of electrophysiology actually happens around the structures that we're talking about here. When we typically implant pacemakers, we're crossing the tricuspid valve for a ventricular lead to go into the right bottom chamber. Some people need what's called a biventricular pacemaker, where we pace the left bottom chamber, and we typically access that through the coronary sinus and one of its branches when we're doing that endovascularly. We spend a lot of time in electrophysiology working in the left atrium for people who have different types of atrial arrhythmias, atrial fibrillation, and such. And the fossa ovalis, which is pictured up in the middle, is how we typically get what's called transeptal access to access the left atrium. When we do flutter ablations for people that have right atrial flutter, it's typically by the eustachian valve going into the inferior vena cava. There are lots of patients who have arrhythmias from the crista terminalis region, which is labeled CT up there. So in this picture, many electrophysiologists breathe and live their professional lives working around the different abnormalities that can exist in this. And since this is an aortic talk, I would also highlight that just above the yellow picture over there is where the aortic root typically sits. So even as we're implanting pacemakers in the modern day, we try to do what's called conduction system pacing for patients that need pacemakers. You either are visualizing when you can visualize it, and for patients that have had aortic valve surgery or have calcification in the aortic root, you can actually visualize it under fluoroscopy or x-ray as you try to do that. And you aim for that region, and then you can look at the different electrical parameters to do that. So I'll move on and talk about AV block, which is common in patients that have aortic valve disease, either as just a progression of the aortic valve disease, because many patients have aortic root disease and they get calcification and fibrosis that extends into the aortic root and oftentimes involves the conduction system of the heart. Sometimes AV block can be caused by medications that are used to treat some of these conditions that are associated. I know colleagues from pharmacy had spoken about some of those medications. Most patients that get beta blockers are not necessarily going to get, AV block from it, but occasionally in predisposed patients, you may see some of that. In the olden days, many patients used to be on this medication called digoxin. There are many patients who require antiarrhythmic medications such as amiodarone, and when those are used over long periods of time, typically sometimes people can get AV block, and this may require permanent pacing. The commonest form of AV block, though, that we see in patients with aortic disease is just degeneration, wear and tear from aging, and calcification and sclerosis of the conduction system, which can be part of normal aging, may not necessarily be associated with aortic disease, but many patients that have aortic, specifically valve disease or aortic root disease, may have a higher tendency of getting this. There are many, many causes that are listed here, and every time that I see a patient, my job is to make sure that it's not one of these causes. Some of them can be, isolated to the electrical conduction system of the heart. Some of them can be part of a systemic condition, sarcoidosis. Some of it can be infection, right? And if someone comes in and they have an acute infection that's involving the conduction system of the heart, putting in a pacemaker without addressing the infection is not the right thing to do. So typically you want to talk about that. I know one of the patient survivors spoke about having endocarditis and such, and I'm actually going to share a case later on of someone who had endocarditis, which unfortunately also presented as an aortic root abscess and AV block. And if you don't connect the dots, you may not always know it, but our job is to do the due diligence and make sure that we look at that. So AV block on EKG, for those that have seen EKGs or had EKGs and looked at their own EKGs and such, would typically present as a slow heart rate where the top chambers, the little blips that you see in the middle, which are the sinus beats, are not communicating with the ventricles through that bridge, which is called the AV node. And sometimes people have an escape rhythm, which is slow, sometimes is unreliable, like this specific patient. They have a very slow escape rhythm, which is wide, which is the bigger squiggles that you see right there. And then the third escape rhythm is coming from a different source in the left bottom chamber. So if this patient shows up in the ER, if they can't get a pacemaker before the sun sets and it rises, a permanent pacemaker, then they should for sure get a temporary transvenous pacemaker, because this is an unstable escape rhythm that is going on right there, okay? Many patients also have atrial fibrillation, and instead of being in normal sinus rhythm where the normal electrical signal of the heart is commanding the bottom chambers to beat through the AV node, when you're in AFib, the left top chamber is quivering and is in control of the beating of the top chambers of the heart. So even patients with atrial fibrillation can get AV block, and the way that it shows up on EKGs is that instead of being irregularly irregular like atrial fibrillation typically is, it shows up as a regular, sometimes slow rhythm. And sometimes it's not too slow, like this specific patient who had AV block. Many times from just looking at the EKG, looking at the history, lab work and such, we can figure out where the AV block is. But occasionally, people wear halters or these wearable things. Maybe someone has felt dizzy or lightheaded. It's not clear that this is related to a slow heart rhythm or not. And occasionally, we actually bring people to the EP lab where we study the electrical system of the heart. We typically go in through the femoral vein, which is in the groin area, and then we put in very specialized catheters that can measure the electrical signal of the heart. So in the picture here, we're measuring an electrical signal in the high right atrium, which is HRA over there, and we're measuring a signal across the natural bridge that conducts electricity from the top to the bottom chambers of the heart, what's called the Hespando region. So in this specific picture, we see that as, if you look at the first beat, for people that are used to looking at EKG, the first little squiggle is followed by a QRS complex. The next one, there's a P wave that's not followed by a QRS complex, and the level of block is in the bundle of His because the His signal is activated before there's any conduction down to the ventricle. So this, again, would be a high-risk situation. So if you saw this just on a Holter, there would be some P waves that don't conduct. You don't know if this patient needs a pacemaker or not. But with an EP study, you can determine that this is a high-risk feature, and maybe this patient may be able to benefit from a permanent pacemaker. Treatment of AV block, again, if it's something transient, or if someone is hemodynamically stable, there's many medications, atropine, there's beta agonists, norepinephrine. If someone was on digoxin and you think they have dish toxicity or calcium non-dihydropyridine calcium channel blocker, you can give glucagon to counteract those. And if it improves and you are satisfied that you've reversed the temporary situation, then there's no specific need for a permanent pacemaker. However, for many of these patients, there's need for permanent pacing. If it's soon after open heart surgery, my surgical colleagues are going to speak here, but many patients who get valve disease also get temporary epicardial pacing wires because sometimes people get heart block, which could be, or different bradyarrhythmias that could be transient in the immediate post-surgical period. And if that persists beyond a certain amount of time, or if it's not going to be reversible, typically we would recommend a permanent pacemaker as well. I'm going to now move on to show some ECGs and review some of the EKGs that talked about this learning objective about AV block and how it relates to the conduction system of the heart. So I know several different speakers, if not almost every speaker who spoke before me today mentioned bicuspid aortic valve in some shape or form. Most of the times when that was mentioned, it was in relation to, the valve disease that occurs with that and the ascending iotopathy and the risk of dissection and such. But, because the valve is functionally abnormal and 1 to 2% of people are born with this bicuspid aortic valve, some people can get risk for getting infections associated with this. It can be from your teeth. Sometimes it can be from other transient causes of bacteremia, which is growth of bacteria in your blood. So this is a patient I saw recently. He's 36 years old. He had a murmur. He had known that he had a bicuspid aortic valve, and he was admitted with fever and dizziness. He came in through the emergency room. His labs were notable for an elevated white blood cell count. He also had a new iron deficiency anemia, which had been progressive over the preceding few months. Blood cultures were obtained, and 4 out of 4 of those blood cultures grew this organism called strep bovis. So typically, when you have strep bovis and it causes endocarditis, you have to be worried that someone may have a colonic tumor. That's a bacteria that exists in the colon, typically. And unfortunately for this young man, that's what he ended up being diagnosed with. Unfortunately, he had aortic valve endocarditis due to strep bovis. His EKG shows a sinus tachycardia with complete heart block and narrow escape rhythm, and he had an aortic root abscess. We have a very young man with a congenital disease. He had developed, of course, infection because his valve is predisposed to that, and unrelated to that, but which helped get this diagnosis, is the microbe that he grew, which showed that he also had a colonic tumor as well. Okay. I had another patient a few weeks ago. Many patients that have aortic valve disease nowadays get transcatheter aortic valve replacements, and the patient had AFib for a long time. They had an uneventful transcatheter aortic valve replacement a few weeks earlier, but over the last few days prior to admission, they've been having dizziness and near syncope, and this is an EKG that shows AFib with complete heart block. So when they deploy that aortic valve, it can compress on the conduction system of the heart, and some people can get heart block with it, and this patient needed a pacemaker as well. Again, in electrophysiology, many times we see people that are older, just because, the conduction system and arrhythmias can be more prevalent in older folks, but we also see a fair number of young folks for supraventricular arrhythmias, Wolff-Parkinson-White, and occasionally we actually get patients like this one who had congenital complete heart block. So some patients, especially if the mom had lupus or circulating lupus antibodies, can be born with congenital complete heart block. Some of these younger children who have complete heart block may have underlying congenital heart disease. AV canal defects, patients with trisomy 21 are at very high risk of getting this congenital complete heart block. So this EKG is showing sinus rhythm with complete heart block. And after a therapeutic intervention, now you can see that the top chambers and the bottom chambers are following each other with a paced QRS that is actually very narrow, because in this patient we're able to put in the so-called conduction system pacing. And some people might look at that EKG and not be able to tell that there's a pacemaker that's working right there. Okay. We also see a lot of patients who have fast chamber or fast arrhythmias from the top chambers of the heart. And periodically after aortic valve intervention, whether it's surgical intervention or transcatheter aortic valve intervention, just because of the changes in the conduction properties of the AV node, some people can get supraventricular tachycardias. So we typically study them, just like normal electricians would do with different tools. You put these catheters, and our catheters are typically deflectable. You can bend it. They have different curves on them. They have a different number of electrodes, so you can actually measure different electrical signals from the different chambers of the heart. And typically, again, unfortunately, I don't have a pointer here, but this is fluoroscopic image in the right anterior oblique, almost like the floor image looking from the right of the patient, about 30 degrees or so. And the wire that's coming down with the 4 electrodes right there is in the right bottom chamber. The wire with the 10 little dots almost looking obliquely across the screen is in the coronary sinus, and that other 4-chamber 4-dot wire that's at the almost apex of that blue ellipse is recording the hispano region. So again, this is very similar, but shown in a different way to that first diagram I showed you about the triangle Coke. So once an electrophysiologist puts these catheters in these positions, you can actually study the electrical activity of the heart in a very detailed way and understand what's working well, what's not working well, what's causing short-circuiting, and you can deliver different treatments. So typically, those catheters would give you recordings that are like this. I tried, and I promise not to bore you with the details of this, but we typically measure the electrical time that it takes to get from the top to the bottom chambers of the heart, and there's normal ranges for that. We figure out after we get the catheters in place, if someone's having a fast heart rhythm, whether they've got what's called dual AV nodal physiology, do they have an accessory pathway, what's called Wolff-Parkinson-White. Sometimes it's manifest, meaning on 12-lead EKG you can see it. Sometimes it's concealed, meaning you can't see it on 12-lead EKG, or it doesn't conduct from top to bottom, but can conduct from bottom to top, but can still cause these arrhythmias. We pace different parts of the heart, the top chambers of the heart, the bottom chambers of the heart. We're literally doing an electrical experiment, trying to see what's working well, what's working normally, what doesn't work, what's short-circuiting, and what are the kinds of arrhythmias that people can experience. And through pacing, sometimes medications, adrenaline-type medications, many patients who have supraventricular tachycardias, sometimes it's provoked by exercise or stress or anxiety or those kinds of things. So we have medications that we can utilize in the lab to try to recreate the clinical scenario that the patient is experiencing. Once we do that, we try to understand, is there a one-to-one relationship between the top chambers and the bottom chambers? Is it what's called long RP or short RP? And that means different things to us. And how does it start? Suppose you start a fast arrhythmia, how does it terminate? And then when you get certain changes in the cycle length, what exactly is happening? And that gives you a very detailed information about what kind of arrhythmia someone may be experiencing. The aortic root, again, like I said, it's not just a bridge for how the electrical signal gets to the bottom chambers of the heart from the top chambers of the heart. But sometimes we do see patients that have these atrial tachycardias, which is a focal source of ectopic electrical activity in the top chambers of the heart, and it's actually localized to the aortic root. And the different pictures that I have there try to show it, with an angiogram. You've got an aortogram in there, you've got catheters, and the red stuff that you see there is when you're mapping on the right side, and it localizes to what's called the his bundle region, but then you know that it's localizing there because that's where you're measuring, but you actually have to measure in the structure that's behind it, which is the aortic root. And there's been numerous case reports of ablations of these aortic root tachycardias. We also spend a lot of time taking care of patients with bottom chamber arrhythmias, ventricular tachycardia, PVCs, and many PVCs. I would say in my practice, maybe 2/3 of the PVCs that I get to see, the so-called outflow tract arrhythmias, actually originate in the aortic root. And PVCs means premature ventricular contraction, and many times they're benign, sometimes they're not. They can cause heart muscle weakening. And I'm going to show and share a case of a 51-year-old female with hypertension, and she had very symptomatic PVCs. She had been tried on different types of medications, including beta blockers, a heart rhythm medication called sotalol, and despite her age and the potential side effects with amiodarone, actually someone had tried to put on amiodarone as well. And her ejection fraction, which is a measure of the efficiency with which her heart functions, was 40%. And she had heart caths, other things, and we concluded that these PVCs, because they were occurring with such high frequency, were likely the reason why her heart muscle was weakened. She was referred to us to figure out what else we could do, and that's an EKG of her PVCs. So they are right bundle morphology. So if you look in V1, typically we look at the axis. They're called inferior axis, meaning they've got a very high peak on the R wave in the inferior leads, 2, 3, and AVF. And you can see that they're dominant across the precordial leads when you look at V1 through V6. So this suggests that this is a left ventricular outflow tract, very basal, possibly from the left coronary cusp. So after we discussed the options with this lady, she agreed to come in for an EP study and with possible ablation. And, this is in the lab, so it looks a little bit different than the EKG. But you can see that we mapped, and in the left coronary cusp, we found this area which was 13 milliseconds. So 13 milliseconds before the onset of that PVC, and looks like this is where it was coming from. Because it's in the aortic root, we have to be certain that it's a good and safe place to ablate. And on this picture, using intracardiac echo, which is a real live image of someone's heart, as we do that, we can see the aortic cusp. So this patient had a tri-leaflet aortic valve, which was otherwise normal. At the bottom of the screen, at 6 o'clock on the screen, that's the left coronary cusp, and that's where we were mapping this PVC to. At about 3 o'clock on the screen, the other cusp that's up there is the non-coronary cusp, and at about 1 o'clock on the screen, 1 to 3 o'clock on the screen, is the right coronary cusp. In fact, in real life, you can actually see the coronary sinus ostia, which you have to worry about if you're on the coronary cusp, because I don't want to deliver heat energy and cause a heart attack in someone. With the ultrasound software that we use when we map, you can actually define those, and you can know within a millimeter of distance of where exactly your catheter is, and you can be sure that this is a safe place to ablate. And on the next image, in what's called the long axis view, you can actually see where deep within the aortic cusp the coronary arteries would come from, higher up and not as deep in the coronary cusp. And this image I also like because it also shows the tricuspid, cavo-tricuspid isthmus, where we sometimes do ablation for flutter and such. And once we were sure that this is where this abnormal heartbeat was coming from, and this is a safe place to ablate, it's deep within the coronary cusp, it's at least 10 or so millimeters away from the coronary sinus ostia, we come on ablation. So at the top of the screen, you see where it says ablation on, maybe halfway through the screen right there. And then you see how there's those little blips. And soon after we come on, there's one blip that comes, and then subsequently the heart rhythm is normal because we found exactly where this extra heartbeat was coming from. So after we mapped in the left coronary cusp, we gave 20 watts of radio frequency ablation, and she had one more PVC, and she has never had any more. I followed this lady for a few years now. Her ejection fraction is now normal. She doesn't take medications, and she's literally discharged from my practice. So I hope I didn't, go way out on a limb to excite you about, the electrical system of the heart, but it's for sure related to the aortic root, and the aortic root and its anatomic relations are critical for normal cardiac anatomy and cardiac electrophysiological disease in the aortic root, the adjacent structures, which we spoke about, and their treatments, these valve replacements or transcatheter valve procedures sometimes result in heart rhythm conditions. Thank you for your time. I will look forward to taking some questions at the end.
Thank you, Dr. Zashiri. Next, we have Dr. Elliot Stevenson from Allina Health Minneapolis Heart Institute, and he will be talking about abdominal aortic aneurysm management. Dr. Elliot Stevenson is a vascular and endovascular surgeon at Allina Health Minneapolis Heart Institute in Minneapolis. He grew up in Minneapolis and attended Washington University in St. Louis for his undergraduate degree and the University of Minnesota Medical School. He completed his general surgery residency and vascular surgery fellowships at Oregon Health and Sciences University in Portland. His professional interests in vascular surgery embrace a broad spectrum of systems, and we are pleased that aneurysms and dissections are amongst that to have his expert eye and hand applied. Thank you, Dr. Stevenson, for your continued efforts for your patients and sharing your treatment process with us today. Welcome. Thank you.
Thank you. It just clicks through. Okay. Sorry. My name is Elliot Stevenson. I'm a vascular surgeon at Abbott Northwestern and Minneapolis Heart Institute. I don't have any financial disclosures for this talk, although I do participate in a number of different endovascular trials for aneurysm repair. But I'm not gonna, this is all just very generic, no specific. There are a lot of different companies that make grafts, but we won't talk about any specific ones. Fortunately, I think there's been a lot of talk about the aorta today so far, and some of the things I won't have to cover as much, but I'm going to focus mostly on the abdominal portion of the aorta. Talk a little about what aneurysms are, and some talk about screening, as I think that's very important for abdominal aortic aneurysm, and then specifically how we manage them. And that's about 90 pages in our sort of manual of vascular surgery, so I'll try to go quickly. Aneurysms are just one, any time that normal artery is dilated 1.5 times. So in the way we normally characterize the abdominal aorta is having a sort of defined diameter of 2 centimeters. So any aorta that is in the abdomen is greater than 3 centimeters is going to be an abdominal aortic aneurysm. And then we mainly define them in relation to the renal arteries, which are unfortunately, the arteries coming off. So the iliac arteries are the bottom arteries, and then the next arteries coming up are going to be the renal arteries going to the kidneys. And mainly focusing today on infrarenal abdominal aortic aneurysm, which is the most common, but basically the entire aorta can have disease, but we really characterize where the aortic aneurysm is based on the renal arteries, because that really changes how we manage them. And so I think we've covered some of this, but the most concerning issue with aortic aneurysms is rupture. And unfortunately, that's often the first symptom that patients may have, and unfortunately, that's frequently a fatal problem. The CT scan on the to the right shows a sort of large amount of blood behind the kidney and by the aorta. That's consistent with that'd be very concerning for an aortic rupture. There's other complications. They can also cause clotting issues. There's either the aortic itself can completely clot off, which can then cause not enough blood flow to the legs or even to the kidney arteries, as well as there's frequently clot that is in the wall of the aneurysm, and that can break loose and travel down and occlude vessels in the leg, like on the angiogram. I think it's been kind of talked about, but the main, really age, smoking, and family history are the main risk factors for abdominal aortic aneurysm, as well as there's a strong male predominance. Atherosclerosis, hypertension, trauma, and dissections are also a part. Screening is really critical because, again, unfortunately, if without screening, frequently the first symptom of someone have is a rupture. And screening really, is fairly easy to do. It can be done with ultrasound. The current recommendations are, at least from the United States Preventative Services, is for all men between 65 and 75 who either have smoked 100 cigarettes in their life or who have a first-degree relative with an abdominal aortic aneurysm should get screened. And there's really insufficient evidence for screening for women, but this is a real problem because women get aneurysms, and sometimes patients may be 76 and they didn't get screening. And so I think screening really should be done for anybody with a first-degree relative. That would be either a parent, sibling, or child. And then again, I think, and that really should be men or women. And then again, I think men who smoke cigarettes are at significant risk, so I tend to screen up to about 80. Above 80, I often don't screen for just because life expectancy. And screening is really ultrasound is really great for screening. However, it's really not sufficient for really defining the anatomy well for management. And so I think the best initial way to find aneurysms is with ultrasound, but CT angiogram is really going to be the best option for defining the anatomy and sort of defining the management. And this is just a CT scans. Used to be CAT scans. Now we really have pretty nice software capabilities, which allows us to kind of look at these images in multiple different dimensions. There's some even more complicated three-dimensional and sort of cross-sectional central lining techniques that can be done. But this is just a video of what we're looking at. This is the aorta. And I don't think I can stop it, sorry. But this is just a relatively straightforward looking aortic aneurysm of approximately 6 centimeters. So the management is really based on size. Size is the best surrogate we have for rupture risk. And so 5.5 centimeters is the standard recommendation for repair for men. Unfortunately, this is really well studied in men. There's basically 3 major trials showing no benefit to early repair. But the problem with these trials is they were almost entirely a male cohort. We do know that women tend to have risk for rupture at smaller sizes. I tend to think that the aorta is probably smaller in size to start with. So 5 centimeters is kind of the standard cutoff for repair of an infrarenal aortic aneurysm in a woman. We also look at growth rate. So if the aneurysm is growing fast, that's concerning for possible rupture. And then symptoms. Again, this is a relatively uncommon finding, but if someone has severe abdominal pain, severe back pain, and we don't have another good reason for why they have this pain, and again, it's usually new pain, unlike anything they've ever had, that's very concerning that this aneurysm, which may have been stable for many years, is now sort of becoming inflamed and may rupture. So for small aneurysms, really just continued surveillance, and I think Ken talked about avoiding fluoroquinolone antibiotics, smoking cessation, And really the risk of rupture for a small aneurysm is really pretty low, and it does increase as the size gets bigger, but again, it's not, I think some of the old papers had said 50% rupture rate. Again, most of the more modern is the annual rupture rate, even in a large aneurysm is probably, 10 to 20% at most. Getting in just briefly to this different, there's really sort of two different techniques once an aneurysm has reached sufficient size to recommend intervention. And again, this is kind of really looking at the unruptured elective aneurysm. There's open surgery, and then there's endovascular surgery. And again, the open surgery is making a relatively large incision and replacing the segment of aorta that's dilated. And then the alternative, and this is more and more the most common way this is fixed in the United States, is with an endovascular repair, or EVAR. And this can be done, this is done by deploying the device through the arteries. Usually access is gained in the femoral arteries. It can be done in other arteries, but the femoral arteries tend to be the best option. And again, a much smaller remote access. And this is sort of just briefly the steps of open surgery, incision. There's a midline incision is one option, and then there's also something called a retroperitoneal incision. It just depends a little bit on the anatomy of the aneurysm and what needs to be repaired. Once the abdomen's opened, the retroperitoneum's entered, and bowel contents are moved to the right, and this allows you to basically expose the aorta and get control of the vessels. Then you basically open the aneurysm sac. Just you want to clamp the arteries very carefully first, but then you open the aneurysm, and there's usually back bleeding from vessels which are oversewn, and then the graft is sutured in place. This would be what we call a tube graft, where it's just a straight tube, but sometimes it's a bifurcated graft, like a pair of pants coming down onto the iliac arteries. And then the graft is the aneurysm flows over the graft to protect it. And then the abdomen, this is basically what the incision looks like for open repair. There's a fair number of different acute complications, bleeding, respiratory issues, cardiac issues, and so it's a fairly significant operation. Frequently, there's about a 7-day hospital course, often a couple days in the ICU following this procedure. And then long term, there's some risk of the aneurysms above or below the repair becoming aneurysmal, also risk of incisional hernia, and then there's some rare complications that can occur with either infection or when the graft becomes somewhat in contact with the intestines. And so the endovascular repair is really the more common way these are repaired in the United States. Again, it's probably somewhere above 80% at this point in time. And again, the main benefit's really the minimally invasive nature of it. The steps for this is really to gain access to the vessels. And again, this can be done with a small incision or with a little bit larger incision, but it's done in the groin. And then basically we put in fairly large sheaths. These sheaths are frequently at least 4 to 5 millimeters in diameter, so relatively large tubes going into the arteries. And then this is an angiogram to identify the landing zone. The angiogram shows renal arteries. They're coming off at different locations. The one going to the screen right is give you the patient's left, and then the right renal is the lower of the two, and that's the one where the graft is going to seal against, or just below. So then this is sort of a cartoon. Basically, once you deploy this graft, it's basically a self-expanding graft, and it opens once you remove a constraining mechanism. So there's different constraining mechanisms, but you basically unsheath the constraining mechanism to allow the thing to open up, and then you have to gain access. This was deployed through the patient's right side, and then you have to get from the left side through that other pant leg to what's called the gate, and then you basically measure and deploy and extend if needed. Lastly, we put a balloon in to seal the proximal and distal seal zones as well as the overlaps, and then take a picture. And then just to kind of highlight how this is done in practice, this is an 85-year-old female with a relatively large abdominal aneurysm. It was measuring just under 8 centimeters. It was a new diagnosis. She had a pulsatile mass on exam because she's fairly small. So you can easily feel this pulsating mass. The main concern really is the angulation of the aorta. Instead of being a nice straight tube with 2 iliac arteries coming off the bottom, it's very angulated, which is not uncommon. Given her age, and she has some emphysema and as well as heart disease, did not think she'd be a candidate for an open repair. And so some patients are not also candidates for endovascular repair, but based on this was really her main option. She has a proximal seal zone, which is adequate for length. It's approximately 20 millimeters. Usually we want at least 10 millimeters, but often the more seal zone you can get, the better. The iliacs have adequate, they're patent and they're of adequate size for a good seal, no aneurysms. And then the femoral arteries, she has previous hip replacements, but the femoral arteries are open and adequate for access. And the issue really is the tortuosity of her iliacs and her aorta. And so all of the endovascular procedures are done under fluoroscopy. So access is gained and wires are placed up, and then everything else is done with pictures, X-ray pictures. And so this is the angiogram we take with to kind of identify the seal zone where the kidney arteries are coming off. The graft is in place. We knew the size we needed, so but this is a little on the high side. So then we deploy the graft, and you can see there's a little bit of the flowering metal, and there's some markers on it to kind of help show you where the graft is. Unfortunately, it's retracted somewhat back from the kidney arteries. It's not retracted a lot back, but there's probably about 4 millimeters or so where it's sort of subsided, and that's not uncommon because the heart's pumping and there's blood rushing down the aorta all while you're doing this. We just marked out the internal iliac arteries. That's the right internal iliac artery. Then the left is marked out, and the graft's deployed. So hopefully you're done at this point. Unfortunately, the completion angiogram shows that we didn't get a proximal seal. There's some kind of gray staining to the left of the graft, and that is consistent with what I say is a large type 1 endoleak. And so basically that proximal portion didn't get a good seal. And so that, again, I knew the graft was a little low, so you can place a little cuff and extend, and then that endoleak had resolved. Unfortunately, the completion at the bottom shows there's actually a leak from the bottom as well. And that's, again, you see there's contrast that's just outside the limits of the graft. And that's really what endoleaks are, is where the flow is still getting in. So the aorta is still intact, and there's no blood leaking out of the arteries. However, there's still perfusion getting into the aneurysm sac. And so endoleaks are the main issue we have with endovascular repair. The one I first showed was a type 1. Those are where either the seal at the bottom or the top is not adequate, and those really need to be repaired right away. Type 2 endoleaks are where there's still flow coming in through the other blood vessels that come off the aorta. There's segmental arteries in the abdomen. They're blood vessels going to the lumbar, and as well as the inferior mesenteric artery, which comes off. And these are variably patent, and they sometimes can cause persistent filling. And then lastly, the type 3 endoleak is if there's the overlap or it didn't seal, or if there's a hole in the graft. And this is actually what I found after taking some different pictures in different angles. There's a little hole right in the left iliac limb. So put another piece in and it's resolved. Endovascular complications really are, the main one is endo leaks. There's about 25% of patients who have an endovascular repair are going to need reintervention for these endo leaks. Endo leaks are even more common. However, not all of them need reintervention. There's also some access complications, and like open surgery, anytime you implant something, there's risk of infection. And sort of just to summarize, open repair versus endovascular repair, there's really not a great, clear, better option. Endovascular repair is associated with a much easier recovery. Frequently, the patients are in the hospital just a day or two. They're back doing normal activities in a week or two. Open surgery is really in the hospital a week and probably at least 3 months before they feel back to how they feel before surgery. So it's a pretty extensive recovery. The benefit of the open repair is it's just a more durable repair. We don't have to image them patients as much. So the annual survey. So after an endovascular repair, we get CT scans every year for basically ever following an endovascular repair. Whereas with an open repair, we usually check every 5 years. And so I think in general, sometimes one option is clearly better from anatomy, patient characteristics, in which case I think then it's pretty easy. But a lot of times patients have, there's choices, and I talk to patients extensively about the choices, and then pick whichever the patient chooses. And this is just this is the 15-year follow-up of one of the big randomized trials looking at this. And out at 15 years, the survival curves are very very much equal. So thank you for your attention. I used to show this picture of Abbott Northwestern. It looks really kind of an idyllic place. That's not what it looks like now, but soon it will be nicer. Thanks.
Thank you, Dr. Stevenson. Next, we have Dr. Sebastian Iturra from Allina Health Minneapolis Heart Institute. He'll be discussing living with aortic disease, a silent enemy. Dr. Sebastian Iturra is a cardiac surgeon at Allina Health Minneapolis Heart Institute, practicing at Abbott Northwestern and United Hospitals. Dr. Iturra completed his medical training at the Pontifical Catholic University of Chile and his general surgery training and a cardiothoracic surgery fellowship at the University of Chile. Dr. Iturra additionally completed fellowships at the Mayo Clinic, Emory University, and the University of Pittsburgh Medical Center. Dr. Iturra practiced as an attending physician and shared his knowledge as an associate instructor in Chile for over 10 years. Before joining MHI, Dr. Iturra was an attending physician at Temple University in thoracic transplantation. His clinical interests are transcatheter valve interventions, aortic surgery, and heart failure transplant surgery. Minnesota is lucky to have Dr. Iturra serve our patient community and welcome him and his family to our great state. Welcome.
Hi, good afternoon, everyone, and thank you for the invitation. Let's see if we can. So, first thing of all, I'll try to keep it under 20 minutes. I know we're a little late. And the second thing, I'll try to keep it as simple. I know sometimes it's very complicated to be very detailed about medical things, especially not medical community. But I think some things I'll try to keep it simple so we can all understand the same conversation. So I have no disclosures, but I'm a cardiac surgeon, and that means I like what I do. That's what I do almost every day, because I really believe we can help people in living longer, improving quality of life, but I also know that it cannot be served for everyone. Now, what we're going to talk today is basically three things. Normal aorta, which probably a lot of us already know after being the last talk of the day. Aortic diseases, we'll base our talk in aneurysm and aortic dissection, and how do we focus our treatment afterwards. So normal aorta, as you probably all know now, is the big artery, it's the big pipe that sends the blood to the rest of the body. Now, when we divide it in basically two main regions, the abdominal aorta and the thoracic aorta, and this divided with the diaphragm, which is the muscle that separates the upper cavity to the lower cavity. Now, to understand, and I know I try to say not very specific, but this is important to kind of understand how to treat this. We divide the aorta in different segments, and we'll talk about the thoracic because as abdominal, mostly Elliot is what he does as a vascular surgery. Now, the thoracic aorta is divided in one segment, which is the aortic root. The aortic root is the beginning where the heart ends and where the aorta begins, and that's where the valve is, the aortic valve, which is part of the complex of the root, but it's also where the coronaries, which are the arteries that give flow to the heart, arise from. Then it's the ascending aorta, which is the portion that keeps going up, and at the neck level, it turns around, which is called arch. And the important thing about the arch, that's where the vessels goes to the arm and basically to the head. So it's a very difficult, complex way to how to treat it. And then it's the descending aorta, which is also an area that we share a lot of how to treat it with the vascular surgeons too. Now, when we talk about pathology now, it's the aortic aneurysm. It means the enlargement of this normal aorta. And there's different segments. Sometimes it can be the enlargement of the root, enlargement of the ascending, enlargement of the arch, or the descending aorta, or the abdominal aorta, as we just heard. So the questions first is, what's considered a normal aorta? And it's not a simple answer to give away because it varies. It's not the same as we grow. As we get older, our hair gets gray, our skin gets more wrinkled, and also our aorta dilates. It's an organ that every time the heart beats, it has to withstand its pressure, and that means it has like a balloon, it's able to expand and then go back to its normal size, but that recoiling effect is being lost by the elasticity as we older we get. So the aorta, when we start at 20 years, it's not the same when we end up with 60, 70, 80 years of age. So that will change with time. And it's also not the same if we're 5 feet versus if we're 6 feet. The larger we are, probably the bigger the aorta. There's also a difference between gender, and that also makes it a little difficult to understand what's a normal size. But overall, to kind of understand, I think less than 4 centimeters, and we tend to talk centimeters just to have an international community agreement, it's considered a normal aorta. Now, what happens when we talk about aneurysm? It's two things. As we said, it tends to dilate, but it's not also that it grows into a bigger size, it also the walls become thinner. And that's why it has a bigger chance of bigger risk of having complications, which is basically the aortic dissection or rupture as we talked before. So that's when it becomes a little more tricky to understand and to follow up what eventually could happen. As you probably heard before, aneurysm, and we talk here, is a silent enemy because usually we don't have any problems, we don't feel it. A lot of us could eventually have this dilatation and not know about it until we have a complication secondary to that. And the estimated around the United States is 5 to 10 every 100,000 people. So it's not very frequent, but it's definitely not none. And we know there's some family trends, some genetics component that many of us could have it. And it's associated with some heart valve disease, as we probably heard before, the bicuspid valve, which is it's not abnormal, but just a variation of normality, can also be associated with aortic aneurysm. Now, when we talk about risk factors, we also heard about this, but I think it's always important to emphasize age. As we said, the older we get, the aorta gets larger. Smoking history has a significant effect. The same cigarette can eventually deteriorate this elasticity component of the aorta. High blood pressure, and it also makes some logic. Every time the heart beats, our aorta is supposed to take this hit of blood pressure. The more blood pressure we have, the more possibility to keep growing with time. We said family history, genetic component, and the bicuspid aortic valve could also be related. Now, again, I don't want to try to be too specific, but I think this graphic is very important because we all have aorta, and so we talked, the more it grows, the more it dilates, the thinner the wall, and the more risk of eventually having these complications, dissection or rupture. And this term is significant about the size, but we know that around 4 centimeters, even though it's not considered normal, all the way to 5 centimeters, it most likely nothing will happen related to this aorta. It's something that needs to be concerned, it's something that needs to be followed, but the chances of having ruptures are very low. But you see, when it's around 55 millimeters, this curve really goes up. And that's when we think the risk is higher. If we have 55, if we have a 65, a 7 centimeters, the more it dilates, the more chance of having eventually this complication. And as we talked, the biggest complication is aortic dissection. And it's hard to understand until actually you actually see it. It's not that it ruptures in half, it's not that you bleed out, but actually it has small tears that makes the blood of this aorta not only be through the normal lumen, the normal tubing, it goes in between the walls. So it's like an onion that kind of dissects into the wall, and that's what we call aortic dissection. And the problem with this aortic dissection is that it's abnormal, you can eventually bleed, but also that you have this malperfusion, which means that not enough blood flow is going to the organs because it's starting to obstruct where actually the vessels are supposed to be coming out. This is the same just scheme trying to show the aorta that has these two sides, blowing the blood through the normal lumen and then through the pathological one. And we probably heard this several times before. The main fastest diagnostic test to figure out about this is the CT. Now, regards symptoms, there's a lot of ways to present this when we have a problem, but the most frequent, even though it's not necessarily most specific, is chest pain. And that's why usually patients, when you talk about how they feel it, the description is to having like a blade going from side to side. And I don't know if anyone here probably has had a dissection or has had a family with one. It's a very critical or very as intense as it can be of chest pain related to it. Now, as some previous speaker mentioned about the critical about time until we actually get the diagnosis and to actually give them treatment, and this is considered the golden hours. There's usually a saying that every hour increases the chance of not surviving. So that's when you have a history of this significant pain, you should go directly to the ED because that means treatment and that means the best chance of having survival and having good outcomes. Now, when we talk about treatment, there's these three big pillars about it: medical, surgery, and endovascular, which is mainly done by the vascular surgical team. And this is all related to location, and that's why I try to focus at the beginning with the anatomy. The aorta or the dissection, we tend to divide in two big groups, type A or type B. Type A is defined by when the ascending aorta is compromised, and type B is when the descending or the distal portion of the thoracic aorta is compromised. And why is this important? Because type A generally have patients that are managed towards surgery. Why is that? Because without surgery, they don't do well. Type B dissection, which is another type of dissection, which is on the descending portion, on the last drawing, is something that can be treated a lot of times medically. And if you have complications, you can treat it endovascular, that means without open heart surgery, and with very good results. It's very, very rare, to say exceptional, that they need open heart surgery to treat that. This is the type B, again, the descending portion, and most of them can be treated medically. And we say medically is controlling blood pressure. That's the main control to be able to prevent this from happening. And if you have a complication, it can be treated with stents. And again, that's vascular surgery where they eventually can help a lot with this. So when we say ascending aorta, the type A is usually that requires surgery. And this is because those patients have this malperfusion of the heart. They tend to have problems with the aortic valve that needs to be addressed immediately, and they have the risk of bleeding. So when we talk about surgery, it's a sternotomy. And I never had heart surgery, but it's a big incision, and it's a traumatic incision. That means having to perforate or break this bone, which is the only way to actually have it done, to have access to all these organs. This is a video. It was not done by me. It's by one of my colleagues to try to understand what the OR means. I try to limit the amount of blood to be shown to try to, again, have a medical thing. But basically what I'm trying to show is that it's a big team. It's a team of surgeons. There's a team of anesthesia below. And this is the heart-lung machine, which is the thing that is necessary to be able to do this heart operation. So we need to be able to draw the blood, to be able to stop the heart, to stop the lungs, and we have this machine that can replace this function, the heart and lung, to be able to do what we need to do. And it's the only way to actually do heart surgery. So what do we do? It depends on what we have. Sometimes we have a root problem, we have to do a root replacement. The most frequent and most standard surgery is just replacing the ascending aorta. We replace it with this tube, which is a graft. It's made like of a cloth, like a shirt, but it's very so tightly knitted that doesn't allow the blood to go from the inside to out. So it just acts as a conduit. There's no rejection to it. There's no specific medications that need to be taken, maybe just aspirin, but it's the only way we can actually replace a tube. So it's a mechanical solution. Now, when this is more extensive repairs, we need to be more aggressive. As we said, there's the arch that can be compromised, and sometimes we have to do a combination between the arch and descending aorta, and also that means that we need to be associated with vascular surgery too. So in other words, it's a team effort, and Elliot, as I spoke previously, we've been up nights trying to help patients in this specific kind of situation. So even though endovascular is a big improvement, and it's definitely the improvement where I see the most benefits, is it's less invasive, so the recovery is faster. as of now, there's no validated treatment for this kind of problems in the ascending aorta. It's because of a technical issue. How do you make sure you don't make the valve not work, or get the coronaries not work, or get compromise of the vessels to the head? So that's a technical problem that needs to be sorted out. There's a lot of investment, a lot of research to get it done, but as of today, surgery is the only way to fix these kind of problems. Not as so as for the descending aorta as we talked, or the abdominal aorta as we heard with the previous talker. So what are our goals when we see a patient with aortic disease? And first is to try to prevent rupture. As we said, it's a bad disease. It's a very complicated disease that needs to be treated emergently. So our hope is to hopefully avoid getting to that level and be able to treat them previously. And for that, we need close surveillance and to perform surgery when it's only dilated but not dissected. And why is that important? Because the results are way, way better. Results regards morbidity, mortality, hospital stay. We're talking here the chance of doing good or doing good is 95%, people being less than a week in the hospital, which is nothing compared with doing the acute dissection. And also another important thing, we're able to, not all the cases, but we can also include to open only half of the sternum. That also means a faster recovery. Aesthetics, I know probably is not the main thing, but it also means a shorter incision, which tends to look better. But I think the important thing is that we can eventually get patients in the pre-complicated state, we can definitely do a safer surgery with better results. Another important thing, which I know we talk about, is that it has to be done on centers that have high volume centers. And as anything in life, the more you do it, the better you get. And I'm not talking only about the surgical technique, there's also the ICU team that gets more exposed to this, a blood bank or the emergency department to be able to recognize this problem sooner and be able to send them to surgery sooner. Because at the end of the day, this is what we want. A patient having surgery done recently to be hopefully active and not have to, for example, from a hospital, go to a rehab facility and spend weeks just to get him out of bed. And this is all centered on the patient. As we talked, there's a lot of different blue circles here, but it's cardiac surgery, which I'm part of the team. But we know that it's not only us, there's anesthesiologists, there's cardiologists, there's vascular surgery. So it's a whole team that is centered to hopefully make the best for our patient. Now, when we talk about medical management, and this is kind of where we're getting at the end of the talk, is what do we do when a patient has aneurysm or already had a dissection? So one thing is exercise and activity. Try to keep them as active, try to decrease the amount of salt so we can have better blood pressure control. Smoking, as we know, has a bad influence regards aortic tissues. Avoiding heavy lifting. We try to recommend not lifting or not doing weight because eventually there's a risk of rupture with that. And screening family members, which we're going to talk about in a minute. And that's because when you have an aortic dissection, there's a 20% chance that your other family can have an aortic dissection too. And this is because there's a lot of genetic components to it. So that's why we tend to recommend people to how to do exercise, how to do follow imaging. There's also a recommendation regards work, social life, sexual life, activities, and also pregnancy in this high-risk population. So as we said, why do we recommend genetic testing? And I'm sorry, I'm late. I know someone talked about genetics before. I don't know how much they actually talk about this. But as I mentioned, 20% of the family members could have aneurysm, and we try to prevent them before having complications. There are a lot of identified genes that can be sorted out. There's three main laboratories, three main testing that can be done today. One of them actually is very close by Mayo, so you can eventually get your test done from the blood work. Sometimes you need anatomy, sometimes you need a piece of aorta of the patient that had dissection, but that can give guidance to prevent this from happening from any other direct family member. And who do we recommend to do it to? When patients have this genetic condition that favors this dissection, for example, Marfan syndrome, Loeys-Dietz, or Ehlers-Danlos. When you have a dissection when you're very young, which shouldn't happen, and when you have a family that had an unexplained death. That's very difficult because there's a lot of other reasons, but one of the unexplained deaths could be related to aortic dissection. So John Ritter, probably a lot of people know him. He was a famous actor in the 80s, 90s. He died of an aortic dissection. And what I say this, basically I was in a meeting, this big surgical meeting last month, January, And there's probably something similar to this talk. There's a woman, that told her story about having pregnancy and having a dissection during pregnancy. She told her story that she was able to survive, her baby was able to survive, but all the problems that was related to dissection in a very critical period. And she talked about this Ritter Foundation, and I thought it was very important, probably something similar as the Aortic Hope that it's in your pamphlet. But there's a lot of alternatives. There's a lot of options, and options because this is a little more farther away from the medical. It's about the patient's experience of how to give support, how to give education, how to try to not get all this wrong information that you can get on the internet if you start searching, and give basically support to patients that have similar problems as one of you guys could be having. So to summarize, and this is the end of my talk, thoracic aneurysms is usually asymptomatic until it has a real severe complications. So our goal is to try to find patients before this problem has, because there's the best chance of having good results with surgery with a faster recovery. And overall, I think it's not a good disease, but there's a lot of things that we can try to do as a medical team. Okay. Thank you.
Thank you, Dr. Atura. Now I would like to have Rock from the Heart's founder, Amy Johnson, come to the stage and say a few words.
What can I say but wow? What an impressive lineup of speakers. Let's give them a hand for today. Fantastic. So, I'm going to keep this short. You don't need to, I had enough TV time this week to last me a lifetime to talk about this, but I want to thank you for being here today. I'm honored to stand before you representing Rock from the Heart. This isn't just an organization, this is a movement. It's a movement that's fueled by the power of education, awareness, and support for individuals and families affected by aortic and heart valve disease. And it's a movement that needs all of us to push forward. Like many of you in this room, I know firsthand how life-changing a diagnosis of aortic disease can be. My husband, Pete, over here, is a survivor of open heart surgery, and our journey led to a mission much bigger than ourselves. We realized that too many people don't know the signs, too many lives are lost due to late diagnosis, and too many families are left navigating this complex medical world alone. And that's why Rock from the Heart exists, to save lives through education, to offer support, and to ensure that no one walks this path without guidance and community. Aortic and heart valve disease doesn't discriminate. It impacts the young, the old, the healthy, the strong, and even those who think it won't happen to me. Awareness and early detection saves lives. And that's why we do what we do today, and every day matters. Since launching Rock from the Heart, we've worked tirelessly to make a difference. We've hosted sessions like this, featuring medical experts. We've shared real survivor stories and provided a platform for patients and families to connect. We've expanded our reach through live-streamed and recorded sessions, ensuring that knowledge extends far beyond this room. And this year, we're taking another bold step by offering free community heart screenings to provide early detection and prevention opportunities. And that will be tomorrow here from 10 a.m. until 2 p.m. But we can't do it alone. This movement is only as strong as the people behind it. So today I'm asking you to take action, not just to listen, not just to learn, but to act. And here's some ways you can help. Volunteer. We need people like you in this room to help at our events. I see many of our volunteers around. Our Target Field team. Woo, woo, woo. Yep, we serve burgers and dogs at Target Field, and the Twins organization makes generous donations to us. We need you to spread the word. Be ambassadors for the cause, whether it's volunteering at our events, working at our concessions at Target Field to raise funds, or helping with the screenings, or just sharing our message on social media. Liking our page, inviting your friends to like the page. Your time and your voice make a difference. Attend. Knowledge is power, and just by being here today, you're already taking that first step. I encourage you to attend future Aortic Ed sessions, our benefit concerts, and awareness events to stay engaged and informed, and bring somebody with you. You never know whose life you might change just by inviting them into this conversation. And the big one is to donate. As beautiful as this is, these are not free to put on. And your support makes it possible for us to keep costs low for those who need it most. We believe that nobody should miss out on life-saving education, a supportive community, or the joy of music because of financial barriers. Your donations help us ensure that Aortic Ed sessions, the dinner, and the benefit concert remain accessible to everyone. Every dollar you give allows somebody to learn, to connect, and to find hope. Whether it's a one-time gift or ongoing support, your generosity has a direct impact on saving lives and making these critical resources available to those who need it most. Rock from the Heart is more than an event. It's a lifeline. It's a promise that no one is alone in this fight. It's a commitment to turning awareness into action and action into change. So I leave you with this. What will you do today to make a difference? Will you make a donation? Will you volunteer? Will you bring somebody into the conversation, like our Facebook page? You will help save a life. The choice is yours, but together we can make a lasting impact. So let's keep the music playing, let's keep the education flowing, and let's keep fighting for those who need it most. Thank you.
Now, Rock from the Heart is excited to introduce a new form of discussion, a physician-patient discussion. Dr. Tyler Wallen is a general surgeon specializing in cardiac surgery, practicing at Geisinger Health in Wilkes-Barre and Danville, Pennsylvania. Dr. Wallen attended the Lake Erie College of Osteopathic Medicine, where he earned his Doctor of Osteopathic Medicine. He followed this with a residency in general surgery at Mercy Catholic Medical Center in Philadelphia, and a fellowship in cardiothoracic surgery at the University of Florida in Gainesville. His clinical interest lies in transcatheter valve replacement and aortic thoracic disease, and treats his patients for a wide variety of cardiovascular issues. Along with being an active member of multiple surgical societies, Dr. Wallen gives of his time and expertise by volunteering with the International Children's Heart Foundation, offering his surgical services to children across the globe. He is joined by Robin Peacock and John Toivoden. Sorry if I butchered that. John shared his patient story with Rock from the Heart last year and has become an integral part of the mission of positive patient mindset. John is a father of 4 lovely daughters, and with his wife, Nicole, lives the Minnesota hockey family life. Thank you, Dr. Wallen, Robin, and John, for this conversation, sharing both the physician and patient point of view on a topic we all know too well. Welcome.
All right, thank you. I can't thank you all enough for having me here. It was a relatively smooth trip from Pennsylvania out here, and although as silly as it sounded to tell my colleagues I was heading out to Minnesota in February, I'm very, very happy to be here.
Oh, that's great. Awesome. Thank you guys for us coming up here. And this is kind of a different thing for Rock from the Heart. I know Dr. Tyler has done this before, patient doctor forum. So we're up here to help with that. So we are very blessed to be invited on this stage with Dr. Wallen to kind of just ask questions and have an open discussion. So we had our introductions, and I think we're just going to kind of get right into it. So I'll go ahead and ask the first question. So we've heard a lot about advocating today, advocating for yourself, things like that. We've heard about patients connecting with their care team, their doctors, their nurses, everybody that's involved with surgery. How important is it to you as an MD to have that same connection back?
It's critical. It's absolutely critical. I think one of the things that attracts those of us who like to take care of aortic disease to the field is the fact that, unlike most of my surgical patients, back to my general surgery days and through my cardiac days, where you sort of have your operation, you have your follow-up appointment, everything looks good at a month, and it's like, see you later, let me know if you need anything. Your aortic patients are patients for life, right? You know, most aortic surgeons are going to see their patients yearly or every other year for either the rest of their life or the rest of your life, right? And so that establishes a much different relationship than most heart surgeons have with most of their patients. That's an attractive thing to me. It's one of the things I like about the field. And I also think it's critical, you know, as some of my colleagues mentioned earlier, even before the operation, it's about balancing a risk and reward system, and that's different for every single person, right? It's obvious to say that the risk of surgery is different in a 55-year-old otherwise healthy person as compared to an 85-year-old with mobility issues. But there's a huge spectrum of things that exist in between that. And only when you have that relationship with your patients can you adequately assess that risk-benefit ratio and then provide the best care that you can for them. So I think it's critical. It's absolutely critical.
That's great. That's great. So I want to ask you if you can talk a little bit about cardiac rehab. So with people that I come in touch with, a lot of people ask, why do I have to do cardiac rehab? My insurance isn't going to pay for cardiac rehab. What can I do? How do you handle cardiac rehab with your patients?
Sure. My personal practice is to recommend cardiac rehab for everyone. I usually see patients at 2 weeks and 4 weeks post-surgery. If everybody looks good at 4 weeks, then I recommend them out for cardiac rehab, and I do that for a couple of reasons. One, I think our physical therapists and occupational therapists are unsung heroes in the medical community. I mean, they do tremendous things for patients. I usually tell folks, I can save your life, but it's going to be the PT who gives you your life back. And that relationship, I think, long-term is really important. The other thing is, you know, we're all busy humans, right? And I'm sure if I asked for a show of hands, there'd be plenty of hands up that'd say, who thought they were going to work out today but then didn't do it, right? And I'm in that group. And I didn't even pack workout clothes, to be honest. But that said, if you have an appointment, most of us are sort of, you know, good patients and good soldiers. We'll keep our appointments. So if I set you up with cardiac rehab and you have an appointment and you know someone's counting on you to be there, you're more likely to go. And when you go and you get the therapies that you need, people recover faster and they have a better quality of life. I have a lot of patients that go once or twice, and then they figure it out and they know what they need to do, and then they can do it on their own and they're really motivated, and that's great. I have other patients that go for 6 months. I have other patients that go for a year. But it's very rare that information's a bad thing, right? So even if you just go once and listen and hear what the therapists have to say and find out what the deal is, that information is valuable in and of itself, even if you never go back. So, you know, my personal 2 cents on cardiac rehab is that anybody who has an operation should make an effort to at least hear what the folks at cardiac rehab have to say. I will also say that there's a lot more avenues now. We do a in-home virtual thing with, you know, we give you an iPad. You don't even have to have your own iPad, and the therapist will meet with you over Zoom and do all things like that. And so there's a lot of opportunities. But I think it's critically important, and I think if nothing else, just having an appointment that you know you have to keep is a good thing.
Awesome. And before we move on, you were so close with my name. It is Toivonen. With Finnish names, you pronounce every vowel. But so close. I never expected people to get it right. So in kind of our pre-meetings leading up to this, you talked about patient follow-up and a lot of the questions that you go through and a lot of the data that you collect afterwards. Can you elaborate a little bit on that for these folks today? Because I think that's very important in the research you do.
Sure. I think I might be, you know, sort of speaking to the choir here, given that you're all here. But, you know, when you have, let's say, a type A aortic dissection that was discussed in the last talk, you know, the area that's the immediate threat to your life is taken care of. That area is resected, replaced with a graft, whatever the case may be. But the rest of your aorta is still in there. And it's still at risk. And we know from other long-term studies that the lifetime risk of needing a second aortic operation, which is frequently an endovascular or minimally invasive operation, is somewhere around 12 to 15%, which in the medical world, 12 to 15% is like an astronomically high number. So follow-up's critical, because if we can identify those folks who need that intervention before a complication or before an emergency happens, just like your first operation, it's going to be much safer. So we know that good clinical follow-up meaning, seeing somebody and talking a little bit on how you're doing, getting the appropriate imaging you need, echocardiograms, whatever the case may be for your situation, is really important. It's important in staying ahead of the problems because playing catch up is always much more difficult. In terms of my own work that you hit on, we up in Pennsylvania where I work, we're an integrated health system, right? We are multiple sites across eastern and central Pennsylvania. We're all linked under one big electronic system, and we're also the biggest insurance provider in the area, right? So theoretically, if anybody should know everything about their patients, it should be us. And we recently went through and we pulled all our aortic dissection patients and saw what was our own adherence to appropriate imaging follow-up, and I'll save you the drama, it was pretty poor. And that's sort of what we like to think of as the best of all scenarios, right? And so we're now looking at ways that we can figure out what leads to that. Are there things we can do better? Are there things we can educate our patients about better that can increase that adherence, drive that follow-up rate higher, and then hopefully prevent some of the secondary aortic emergencies that we come in contact with?
That's great. I just had a question. And with brain fog, pump head.
Very real.
Very real.
It's very real.
So one of the things that I was struggling with or challenged with when I was diagnosed in 2007 was the limitations. Once I learned that I had the aneurysm, I had exercise limitations, I had heart rate limitations, those types of things, but yet diet and exercise is super important. But here I am, I'm not supposed to have my heart rate over 120, and I'm on all these medicines to keep my heart rate low. And so how do you handle that when you've got a patient that obviously struggles with weight, but needs to exercise, needs to keep going? Because I do think that going into open heart surgery with a stronger heart muscle helps with the better outcome.
Yeah, and I think you hit it right on the head in that exercise is good for everybody. It's good for people with and without aortic disease, right? And so I can give you how I handle exercise for my own patients. I would leave the caveat that this is by no means endorsed by the American Heart Association or anybody else. But I usually tell my patients that aerobic exercise is fantastic for you in a variety of different ways, not only from your cardiovascular, but also your cardiopulmonary, your mental health, all that sort of stuff. So if you can get out and even do something as simple as go for a walk every day, that's going to be phenomenal for you. We often think of exercise in terms of what we grew up with, right? So my boys are in the hockey playoffs this weekend too, right? So we think of exercise as being out there and skating suicides until you're covered in sweat and you're collapsing on the goal line and you can barely catch your breath, right? And that is a form of exercise, but it's by no means the only form of exercise. So things like walking, light jogs, swimming, cycling, the elliptical, they're all sort of low impact, low stress activities that will still provide you the benefits of cardiovascular fitness. So I usually tell patients that from an aerobic standpoint, I would give you free rein. You can do whatever you want, whatever makes you happy doing cardio work. There are people who put heart rate constraints on some exercise. I usually don't get that sort of nuanced with it. The vast majority of my patients are on a beta blocker, so typically that's sort of a little bit protective. And then even for lifting, I tell people if you can lift something and hold a conversation while you're doing it, that's okay. If you have to hold your breath, if you have to squeeze your belly, if you have to grunt, if you have to stop what you're doing, then that's probably too heavy. Right? And so, cardiovascular fitness and exercise is good for everybody, and it's good for people with and without heart disease, and it's particularly good if you are in your situation where you're preparing for an operation. As simple as it sounds, the better you are going in, the better you are going to be coming out. So coming up, showing up fit is important. The other thing I'll just touch on that you mentioned is a good diet, right? So anybody who's visited their cardiologist has probably been told about the importance of diet. I usually tell patients, we had a saying when I was in Florida, which is that you get fit in the gym, but you get skinny in the kitchen. And so, a good diet and all the things that go into a good diet are just as critical as exercise.
Thank you.
Awesome. So now up here, you are not a scary doctor. You're just a guy talking to a crowd of survivors.
I hope
okay?
I'm never the scary doctor.
Right, exactly.
Yeah, that's fair.
So what can you, as an MD, tell us as survivors, because we've heard kind of a theme today that sometimes us as patients don't want to speak up. We don't want to advocate for ourselves. We don't want to ask the questions. We just want to follow the regiment. We don't want to challenge. What can you tell us as patients here now that would give them ease to speak with their medical professional about those questions, those concerns, and things that they have going on?
Sure. I think there's a couple of things. Some of them are kind of half funny, half serious, and others are not. I mean, first and foremost, I would say most of you guys probably pay your health insurance premiums, right? And you go to the doctor and you pay your copay. So you're paying for that time, right? So it's well within your right to use that time as you see fit. Just as it's well within your right to ask any question that you want or take the conversation whichever way you want to go. I know that's almost sort of a silly economic version of it, but don't forget that, right? You guys are the ones who are in control here. And second, I would say, I love a good educated patient, right? When you sort of have to start off on, a very basic level of what's the anatomy and physiology of how the heart works, it can take a long time to get a patient to understanding their disease. When a patient comes prepared and they've done some reading and they have very pointed questions, I mean, I personally find that very enjoyable. It's a much better experience for me when I have someone who I know, okay, this person's invested, right? This person wants to know, they want to understand, they want to take care of themselves. Those are the kind of patients we all hope we have. I understand that probably not every physician in the world shares that viewpoint, and there are some people who practice in a paternalistic fashion where it's sort of like, this is what we're going to do, boom, 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 move on, next, I got an appointment every 15 minutes for 9 hours, so I got to go, right? And that's out there, and it certainly is. And I would say, one, you should never be intimidated by the fact that, you're dealing with someone who's a medical professional, right? We have a high amount of education and training in a very narrow field, right? That doesn't make us some type of superior being, right? That just gives us training and education in a very focused fashion. So there's no class system when it comes to your interaction with your healthcare providers, and you should keep that in mind. And then the other thing I'd say is, and I almost hesitate to say it out loud, but don't be afraid to walk away. I mean, if you have a practitioner that you're not jiving with, that you're not getting what you want out of, it's okay to look elsewhere. It's not your wife, it's not your husband, you're not breaking up with anybody. Like, that's just the way it goes, right? And so, if you have somebody who doesn't provide the things that you think you need, it's okay to look elsewhere. And I think there are a lot of places, there are a lot of people who we heard earlier about transfer, right? There are a lot of people who can't get transferred for whatever reason. They're too critical, they're too sick, whatever the case is. So they get taken care of in a hospital and they get a good operation and they survive. But when it comes time for follow-up, that might be the time, to sort of transfer yourself to a place that has more of the resources that you need or provides more of the things that you think you need moving forward, right? Every relationship's a two-way street, and the surgeon-patient relationship has to be a two-way street too. And so, I think that if I could, the sort of take-home points would be, one, I enjoy it. A well-educated patient is a pleasure for me. Somebody who comes in and they're informed and they want to talk is an enjoyable, experience. The hardest question I answer in my entire career is, what would you do if it was you? Because, I don't know what to say, because whatever I say, they're going to say, okay, that's what I want, right? And so it becomes very, very difficult because I'm not you, only you're you. And as silly as that sounds, that's really important. So, I would say it can be uncomfortable, right? Whenever there's this knowledge gap that seems so huge, but you kind of have to get over it because that's the best spot for you to get what you need out of your healthcare team. And then the other thing I would say is if you've got somebody who just shoots down your questions and won't address you, that's probably not the person you want to be taken care of by.
I have fired 2 doctors, by the way.
And I'll try not to make it the hat trick.
Exactly. Don't make it the hat trick. And just to add to that, I would like to say that, we trust in our medical providers to guide us in the right direction, but they're not going to have all the answers. We're the ones that have had our chest open, not them. So that's one thing to remember as a patient. But if you have a great medical team, they should be able to point you in the right direction. And before we end this, I just want to go ahead and thank Amy and Pete once again for putting on this event. It was such a wonderful event again. Thank Megan for the great speaker lineup. This has been awesome. Thank you very much. All the speakers, everybody that came here today. So to finalize it, Dr. Tyler, what would you like to leave this crowd with as a lasting impression?
Yeah, I think first of all, everybody needs to understand, this is geared more towards the patients and the survivors in the room, that this is a Herculean task that you're undertaking. I half joke with my patients, but I mean it. This is enjoyable for me, right? I like operating. But this is the 180-degree opposite for you guys. So, give yourself the grace to recognize how difficult this is and how well you're doing at it, right? So that's number one. And I think number two would be to remember that if you just looking around the room, right? So we have colleagues in electrophysiology here, cardiology, pharmacy, vascular surgery, right? So the only person who really talks to all of us is you, right? So don't forget that you're at the center of your experience, and that you have to be the advocate who gathers all the opinions. You have to be the one who reaches out when you need it and understands what you need moving forward, because we're one part of a big team. Like, obviously every team should have a quarterback, and we hope you all get, what's the appropriate reference? It's probably not Tom Brady in this crowd, but something of that nature. Jalen Hurts in my case. So
Fran Tarkenton.
And remember that control rests with you ultimately. We are here to help, but ultimately the control and everything moving forward has to come from you guys. And obviously, by just being in this room, you're already stating that you're really good at that. So don't forget that.
Awesome. Give it up for Dr. Tyler. Robin, thank you once again, guys.
Thank you again to all of you. At this time, we're going to have our Q&A session. Or if you have questions and haven't turned them in yet, you can bring them up here. None? Maybe a few? Oh, thank you. It's okay. I'm pretty good at cursive. And then do our providers have microphones already? We're good? Okay. All right, our first question. Are there implications for a second valve replacement when the first one included a replacement of the ascending aorta through hemiarch?
Hi, back here. So the question is, if you can get your valve replaced if you already had a surgery done?
I believe so. That's what I'm understanding.
So yes, I mean, we can do a lot of things, thinking we can redo or go back into the chest after a previous surgery. It makes surgery a little more complex because we don't have the same structures. The planes tend to be more stuck, so it's always a little difficult to get it back inside. And that's why all this percutaneous technology through catheters has been so beneficial, because they decrease the chance of complications getting in. For example, if the aortic valve is the one that's diseased, a lot of patients can get a TAVR, but that has to be assessed by patient case.
Perfect, thank you. Our next question is, if I am allergic to surgical hardware, would I be able to have a mechanical valve? Have patients experienced issues with stents if they are allergy or sensitive to metal?
I can't comment on the valve. In general, not too. It's been reported somewhat about. So the majority of stents are either stainless steel or nickel titanium alloy. So nickel allergy is always a big one. But it fortunately doesn't come up too much. Again, it's just where the stents are placed. They're often fairly covered, depending on what fabric. But again, if a patient does have an allergy to metal, you might want to think about maybe avoiding a stent. There might be some other options.
Perfect, thank you. Next
sorry.
one, which is the best?
I can make a different comment about it. With the aortic prosthesis, there's a lot of different types. Obviously, the big two groups are mechanical versus tissue. Most of the tissue valves are made of either cow or pig. They do have a metal piece inside. There's also full porcine roots that does not have any foreign materials, just the tissue of the pig. So there's alternatives that can be used on patients that have allergies to something specific.
Perfect. Our next question, which is the best heart care hospital in the Twin Cities? I didn't write this. I didn't write any of them. Who's going to answer this?
Hi. I would say the hospital where you go, where you feel the providers listen to you and provide the best available care for you.
Great answer.
So I'm personally biased. I work at Minneapolis Heart Institute. There's about 100 of us. In my specific practice, 10 of us trained together at Cleveland Clinic, and we've recruited many people from all over the world. So when I see the care that I see here, and I've had the privilege of working at many internationally renowned hospitals, I would say, wherever you get the best care, but I think you should take a look at us too.
I have a unicuspid aortic valve. Any evidence of specific genes for this defect?
Oh, is it? I would say that unicuspid aortic valve-ish is in the VAV spectrum. There are no specific valves for that type of valve defect. I would say often we see it too in kids with congenital heart defects and intellectual disability that can go along with some like intellectual disability, multiple congenital anomaly syndromes, but as an isolated thing, no.
Perfect, thank you. Do changes in digestion impact my INR if I take warfarin?
Yeah, good question. So changes in digestion, I would say just in general when we're looking at INR, so diarrhea is a big one that can contribute and can lead to fluctuations. So I guess, I don't know where the question came from, if there was a specific in terms of like, is this more acute changes in digestion or kind of a chronic picture?
Next question.
Yeah, so
Perfect.
just to kind of wrap that, so yes, I'd say acutely diarrhea certainly can. In terms of chronic changes, we do see like in cases where someone has a gastric bypass procedure where we do have changes just in how the stomach is processing medications as well as food, that there can sometimes be changes, and especially, it's maybe going off on a tangent, but right after a gastric bypass surgery, we can see big changes in INR and warfarin requirements. So hopefully that kind of answered the question.
Perfect, and hold on to the mic. I have another one for you.
Sure.
Are there any medicines on the horizon to replace warfarin to use with mechanical valves?
Yeah, great question. So as I kind of had mentioned in my talk, so at this point, the kind of alternative anticoagulant, oral medications called the DOACs, at this point, none of them are likely to be studied again just because the one dabigatran that was studied in that population showed worse outcomes. So out of what's out there now, I would say no. I haven't heard of anything on the horizon, but that's not to say, not possible. There are some kind of similar agents to the DOACs that are kind of slightly different pathway that, I haven't heard anything as far as studies looking at that, but I think it's going to be a tough population to study just based off of what's been seen in the risks so far with, other DOACs. Good question.
Thank you. Can aortic regurgitation contribute to significant amounts of PVCs and SVTs?
So any kind of valve disease that leads to changes in the loading conditions of the heart, and with aortic regurgitation, sometimes you have high end diastolic pressures and such, and that can for sure increase the number of PVCs from stretching of the left ventricle. Similarly, with the high end diastolic pressure, those people may have elevated atrial pressures, left atrial pressures, and they're predisposed to getting atrial arrhythmias such as atrial fibrillation and atrial flutter. So, The heart is an interesting organ in the sense that, the pumping function of the heart or the mechanical function of the heart is very linked to the electrical activity of the heart, and sometimes the electrical problem causes some of the structural and functional problems, and sometimes it's the other way around.
Perfect, thank you. Next question. What should you do or not do if you have a bulge in your aortic graft or stent? How do you prevent this from bursting?
I think it depends a little bit on what the bulge is. Sometimes if the aneurysm is still present if the patient had an endovascular repair and there's still the aneurysm there, it kind of depends a little bit on how sort of pressurized that bulge is. And then there's certain irregularities that can occur next to a repair, like called a pseudoaneurysm. And those are usually more of a concern, and then you'd really want to kind of limit really exertional activities just to, but I think the most important thing is to really figure out what this bulge is, and so that it can, because again, it could be something that's probably not too big of an issue, or it could be a real concern.
Thank you. Many aortic dissection patients think they aren't at risk for a AAA. Is this true or false?
I would say that's false, if I had to pick one. First and foremost, we sort of know that anybody who has an aortic aneurysm in one location has somewhere around a 20 to 30% chance of having another one. The most common form of aortic dissection that we see is, on the cardiac side anyway, is what we call the DeBakey type 1s, where the whole aorta is affected, right? So when that happens, your whole aorta is no longer normal. So you're at an increased risk of what we call aneurysmal degeneration of the remainder of your aorta, which sort of dovetails into the comments I made earlier about the importance of regular follow-up. So briefly, yes, I believe that's false. And sort of more detailed, it's that once you have an event, your aorta has declared itself as sort of not behaving properly, right? So the rest of it cannot behave properly down the long term as well.
Thank you. Piggybacking off of it, are they genetic?
Are you referring to AAA?
Yes.
Abdominal aortic aneurysm?
Yep.
There probably is, well, one, the genetic aortopathies, connective tissue disorders, can definitely predispose to abdominal aortic aneurysms. I'd be curious, my question I didn't submit to the vascular surgeon was, I don't know if there's any data to suggest with BAV and aneurysm if AAAs are increased. But there likely is a genetic component to abdominal aortic aneurysms. We do see them cluster rarely in families. Again, when we think about genetics versus environment, right, the take-home lesson is if it's early onset in a generally healthy person, more likely to think genetics. If it's later onset, someone who has sleep apnea, cholesterol issues, obesity, issues, it might be more environmental, and those things can also cluster in families. So right now there's no specific gene test for abdominal aortic aneurysm. If it's isolated, if you have a thoracic aortic aneurysm and a AAA, you might want to consider genetic testing. There have been studies where we look at large populations of people with aneurysms and then compared to the general population without. And we say, oh gosh, are there some minor genetic alleles, loci, variants that are increased in this population and decreased in this population? And there might be some associations, but definitely not anything that would predict risk or that you would use to help other family members. So likely genetic, but not ready for prime time at all.
She can keep the mic.
Okay.
How many, I'm going to butcher this again. How many aortopathy genes are there? Did I say it right?
Yeah.
Okay.
Or aortic disease. You can always just say aortic disease instead of aortopathy. It's a challenging one. Great question. I would say somewhere in the range probably of about 40 to 50. I think we are finding more genes. That's why genetic testing, especially if you have a familial component, can be very helpful because we are discovering new things if it's unique to your family. The caveat is that a lot of those panels are going to test for like the lowest hanging fruit, the most likely conditions that go with aortic aneurysms. Aortic aneurysms can also present with chromosome disorders or other genetic syndromes where, again, there might be other congenital anomalies or intellectual disability. So that's why a geneticist who's taking a really good, or a genetic counselor, a really good family history, medical history, will help you find a really good genetic testing plan for you and your family specifically.
I'm going to piggyback again. How often should you be retested?
Great question. I'll be honest. So genetic testing technology, we started with like a single gene, and then we went to like a panel of genes. And technology is moving then to a technology called exome or genome sequencing, which means instead of testing for 40 genes, we're going to test all 23,000 genes. Sounds great, like you're going to find everything. You're not. We only know a portion of what those genes do. And so a lot of testing companies are putting their resources behind this whole genome exome, testing all thousands and thousands of your genes, and not investing in updated panels. And so the panels for aortopathy testing haven't really changed since about 2018, 2019, even though we've discovered new genes. So if you've had testing within like the past 5 years, there's not really a lot of new genes added. I think we're gonna just go to that whole exome sequencing, whole genome sequencing in the next 5 years. That is actually good news because once your DNA is sequenced and fully sequenced, your DNA doesn't change. So you will always have that DNA sequence so that we can keep going back to it to look for new changes. I will say something about that too, is that, you know, if you do have a family history and you haven't done any genetic testing, you should do that. But a lot of people get genetic testing for their family members, right? Like, I'm not worried about you, I'm worried about my kids and my grandkids, and I wanna know what's going on for them. In that circumstance, you know, depending upon your insurance and circumstances, getting a whole exome, getting a whole genome, and having that DNA data that is like a legacy gift to the next generations to learn from your medical health is something, you know, that you could talk to your genetics doctor about too.
Thank you. Before our special video, I would like to thank Dr. Kevin Harris for inviting his Minneapolis Heart Institute colleagues to Rock from the Heart today. Can we all give them a round of applause? Lastly, before we wrap up, we have a special video from Senator Amy Klobuchar.
Hello to all my friends at Rock from the Heart. I wish I could be there with you in person. I hear you're being treated to a performance by the Spin Doctors. That's so fitting because, as they said on their third album, you've got to believe in something. Well, I believe that the power of all the patients, survivors, families, and advocates gathered today, with that help, we're going to win the fight against valve disease. This fight couldn't be more important. We all know the numbers. Over 11 million people in the U.S. have valve disease. That includes 1 in 10 Americans over 75. Yet 3 out of 4 people know little about the disease. Of course, we know this isn't all about those numbers. It's about our moms and dads, aunts and uncles, grandmas and grandpas, friends and neighbors. By being at this event, you're raising awareness. You're saying to patients and survivors in Minnesota, we've got your back. You're doing your part to save lives. It's on all of us to do ours. That's why I continue to fight for strong research funding for the Centers for Disease Control and Prevention and the National Institutes of Health. For the last 10 years, I've worked with my colleagues to increase federal funding for medical research grants, disease surveillance, and disease prevention. But as many of you know, the administration wants to downsize the number of NIH researchers and put politicians in charge of approving NIH studies, which could roll back the progress we've made toward preventing and treating valve disease. Know that I'm going to fight back against any reckless efforts to cut federal investments in medical research or to lay off scientists and researchers or pause NIH grant reviews, because every dollar we put into research today, it gets over $2 out of it for our economy. It paves the way for the cutting-edge treatments and cures of tomorrow. I know this is going to be a fight, But I know that together, patients and families, lawmakers and advocates, we can end valve disease as we know it. If you're living with valve disease, know that you're not in this fight alone. Your families and loved ones are with you. Everyone gathered today is with you. I'm with you, sending you strength and love, and I will never give up the fight to raise awareness, find better treatments, and save lives. Together we are unstoppable. Thanks, everyone.
Before our reception that will be happening just outside these double doors, I would like to say thank you to Amy for having me here today, and to all the survivors, clinicians, and providers for speaking. Can we all give them another round of applause?